On the mastoid process, means,
how do you trace?
Just anterior to the insertion, there will be the main nerve drum.
Digestive has got a medial border and a lateral border. While the digestive, you go deeper to find the nerve. Medial border, lateral border?
Medial border.
Medial.
And lastly, sir, the stylomastoid artery, which enters the stylomastoid foramen. It's a branch of the posterior auricular artery. The nerve lies behind the stylomastoid artery.
Okay. So you trace the facial nerve. As it exits from the stylomastoid foramen, you got to find the facial nerve. You trace the nerve. How it goes? What happens to the main trunk?
So it enters the
any branch as it exits from the stylomastoid foramen?
Yes, sir.
What branch comes from the trunk as it emerges stylomastoid foramen?
The quarter tympani branch.
Quarter tympani. Yeah. It gives you muscular branches. What muscle is there in the back? Supplied by facial?
Sir, it gives two branches, temporofacial and cervicofacial.
No. That is the main trunk dividing. As it exits, it gives branches to the occipital vein, occipital frontalis. It gives a tympanic branch. And then the main trunk divides. What happens?
The main trunk divides into two branches, cervicofacial and temporofacial, which enters the gland. Cervicofacial is below and temporofacial above.
Trace cervicofacial. What happens to that?
Cervicofacial gives the marginal mandibular and the cervical branches of the facial nerve.
Only two?
Yes, as far as I can remember.
What else? Then trace upper?
Temporofacial, temporal branch, zygomatic and buccal. Buccal again divides into two, the upper buccal and lower buccal.
Lower buccal comes from cervicofacial. How do you find the parotid duct during surgery?
So parotid duct actually emerges from the deep lobe of the parotid gland. It lies over the masseter muscle and at the anterior border of the masseter muscle it turns and pierces the buccinator, which ultimately opens opposite.
Why do you find, what is the guide to find the duct?
So actually it lies over the masseter muscle 1 centimeter below the zygomatic arch.
Zygomatic arch 1 centimeter? No. There is another important marker. You draw a line between the tragus and the angle of mandible. Why do you find the nerve?
So middle 1/3 of the line.
If you have both the buccal nerve being delineated, where is the nerve in between the buccal nerve?
So buccal nerve actually lies just above the parotid duct.
Both?
No, upper buccal.
Yes.
And lower
So you find the duct lying between the two buccal branches.
You've done the parotid.
After the feature of malignant parotid.
Features of malignant parotid can be a rapid increase in the size of the tumor. There can be involvement of the adjacent structures, namely the facial nerve, the masseter muscle or the temporomandibular joint, and there will be impairment of the functioning of the muscles of the joint. There will be overlying skin changes as well. And if some of the carcinomas can have a perineural spread to the base of the skull, and obviously the lymph node will be affected.
What are the possible complications?
Complications of malignancy. Parotidectomy. Okay. The complications of parotidectomy, firstly, hemorrhage can be there. There can be infection. There can be flap necrosis. There can be inadvertent injury to the facial nerve or the auriculotemporal nerve, which can later give rise to Fraze syndrome.
How do you handle the complication during operation?
Parotid fistula formation can be there.
How are you going to manage the intraoperatively? You have found that there is a facial nerve injury.
So intraoperatively we can, if already diagnosed facial nerve injury, a nerve graft can be used. The nerve graft is usually taken from the greater auricular nerve.
If the injury is found on table, it depends on whether the injury is just a cut injury or whether there is a loss of the segment. If it's just a cut injury, it's to suture. If there is a loss of segment, you put in a nerve graft. Okay. Second, you have not found on the first day, post-operatively, the patient has got a facial palsy. how do you handle this problem?
Sir, most of the cases of facial nerve palsy that's diagnosed postoperatively will resolve by its own. Even if it doesn't resolve, then there are some static measures and some dynamic measures. Static measures basically.
What is the patient's problem? I mean, these static and non-static procedures, dynamic procedures will come later. The patient's problem is
deviation of the angle of the mouth.
that you cannot do anything right now. You can have physiotherapy, but the patient's primary problem will be exposure. What solution to do that?
So artificial tears can be given. For that.
Padding of the ear, padding of the eye,
Padding of the eye.
artificial tears, etc., you've gone. Then it's a late established neural praxis, which is not recovering. So that means that nerve injury is established. Then what you do?
Then corrective measures have to be taken, sir.
Like?
Some corrective measures helps in correction of the deformity that is caused. For example, if there is a facial deviation or the angle of the mouth deviation, a temporal sling can be given, or sir, if for lateral tarsorrhaphy can be done, or medial canthus reconstruction. All these procedures helps in correction of the problems. But the main problem about the nerve trunk or the nerve trunk problem, for that nerve graft can be done, or muscle transfer from the temporalis area to the masseter area.
You're a bit confused. If you've got a nerve problem, and it is established, then you have two options. One is a nerve-based reconstruction, which means that you can, facial reanimation can be done. You use the cable grafts from one side to the other side so that it can be regenerated, right? It's called the crossover facial reanimation, right? It's a microvascular procedure. Second is you can address the exposure keratitis by different surgical techniques. One is lateral tarsorrhaphy. You can put some weight so that it hangs down. Or you can provide dynamic correction by temporalis to orbicularis oculi and masseter to the orbicularis oris. What is the problem with this? The problem is that it is going to be not a volitional smile. The patient will have no emotions. The patient has to clench the teeth because it's supplied by the fifth nerve. You have to clench the teeth to smile, right? So there is not going to be an emotional smile, right? You understand what I'm trying to tell? So these are the procedures that we are going to do. Next complication.
What is Frey syndrome, you say?
So Frey syndrome is actually pseudosynapsis syndrome. It's basically there has been an injury to the auriculotemporal nerve. Now when the nerve regenerates, it's basically synapse with the sympathetic neurons supplying the sweat glands over the area.
How does the secretomotor fiber reaches the parotid gland, starting with the salivary nucleus?
So parasympathetic secretomotor supply to the parotid gland. The pathway starts from superior salivary nucleus.
Parotid doesn't come from superior. Inferior salivary nucleus. Then higher what?
So the inferior salivary nucleus, then comes the glossopharyngeal nerve,
Yes.
tympanic branch,
Yes.
tympanic plexus.
Yes.
From there, lesser petrosal nerve, which basically lies in the otic ganglion. From the otic ganglion, the postganglionic nerve fibers are carried by the auriculotemporal nerve to the parotid gland.
Good.
Last question to you. What are the other types of parotidectomies?
Other types of parotidectomies.
You have said
Yes.
about superficial parotidectomy. Just 1, 2, 3 names. That's all.
So total conservative parotidectomy, radical.
Means
So it's removal of the deep lobe and superficial lobe both, but there has to be preservation of the facial nerve.
correct.
Radical parotidectomy, where the facial nerve is basically sacrificed along with the soft tissues, and sometimes the temporomandibular joint has to be done. And lastly, a new technique, suprafascial parotidectomy, which is basically employed in cases of adenolymphoma involving the tail of the parotid gland.
Okay. So as Sir has said,
There cannot be radical parotidectomy nerve sparing.
Yes, sir. If the nerve is not involved, then we can spare them.
yeah. So that's it from this side. Thank you very much.
Thank you, Dr. Abhishek. Now, I would like to call Dr. Cherry John from Bokaro General Hospital, Jharkhand, for his presentation on soft tissue sarcoma limb. And the paneling will be done by Dr. Nirmal Kumar Sinha from Patna, Dr. Ashish Kumar Jha from Patna, Dr. Nishit Ekka from Ranchi, and Dr. Shogat Shamanto from Kolkata.
Morning, Manalo gathered here. Myself, Dr. Cherry John, second year DMP resident from Bokaro General Hospital. Today I am presenting a case of soft tissue sarcoma extremity under the guidance of my unit head, Dr. Anand Prakash, and my HOD, Dr. Satish Chandra Kumar. 30-year-old gentleman, resident of Bokaro, shopkeeper by occupation, lower middle class family, came with complaints of swelling over the left thigh for 6 months and pain at the site of the swelling for 1 month. The patient was apparently alright 6 months back when he noticed a swelling over the left thigh, serious in onset, was small in size until it grew rapidly for the last 1 month to become 4 times the initial size. He was also having mild dull aching pain in the swelling for the last 1 month, which was insidious in onset, vague in nature, presenting throughout the day without any radiation and with no aggravating factors. The pain was relieved with medication. He was referred to Ranchi for further management. There is no history of trauma at the site, no history of any childhood radiation, no history of fever, weight loss, loss of appetite, no history of distal limb swelling or swelling elsewhere in the body, no difficulty in walking, no history of tingling, numbness or weakness of lower limb, no history of any distant metastasis like difficulty in breathing, chest pain or cough, headache or visual disturbances or other bony painful swellings or abdominal distension. Coming to past history, there is no history of any long-time illness like hypertension, diabetes mellitus or TB. History of major surgery for similar swelling in the same site was done twice, one 3 years back and the other 2 years back, and he was given radiotherapy in the post-operative period. Personal history, his diet is mixed, his sleep pattern is normal, and he has normal appetite and normal bowel and bladder habit, no addictions like smoking or alcohol. No history of any malignancy in the family. Summarizing my history, 30-year-old gentleman complains of swelling in the left thigh since 6 months, insidious in onset with rapid increase in size for the last 1 month and associated with dull aching pain. History of similar swelling at the same site 2 years back, for which surgery and radiotherapy was done. General examination. The patient was examined in a well-lit room in adequate position as and when required after his informed consent. The patient is conscious, cooperative and well-oriented to time, place and person. Gait is normal. The performance status according to prognostic scale is 80. BMI of the patient is 22.8 kg per meter square. Nutrition is adequate with moderate build. Blood pressure is 128 by 72 mm of mercury measured in right arm in the supine position. Pulse rate is 72 per minute in the right radial artery with normal rhythm and volume. There is no pallor, icterus, clubbing, cyanosis or lymphadenopathy. This is a picture of the case. This is a comparison of the both lower limbs. The swelling is present in the left lower thigh. Examination of the swelling. There is a solitary swelling in the left lower thigh in the medial aspect of approximately 7 to 5 cm size with ovoid shape and the surface is smooth. It has ill-defined margins. The skin over the swelling is normal and the skin has two longitudinal scar marks of length 6 cm and 4 cm, which is 1 cm apart, and there is dark pigmentation around the scar. There is no distal limb edema, redness, dilated veins or loss of hair. No distal muscle wasting, no visible inguinal swelling. On palpation, the findings of inspections are confirmed. An overt swelling of approximately 3 to 5 cm in the left thigh in the posteromedial aspect involving 40% of the circumference. Lower border of the swelling is 3 cm from medial condyle of femur and upper border is 30 cm from the pubic tubercle. There is no local rise of temperature. There is mild tenderness present. Firm in consistency. The skin is pinchable over the swelling. In supine position, there is movement of swelling perpendicular to the axis of muscle, but no movement along the longitudinal axis of muscle. The movement is restricted on contraction of the muscle. No restriction of knee joint mobility, no popliteal or inguinal lymph nodes palpable, distal pulsations present, no sensory motor deficit, there is no history of muscle wasting, there is no distal muscle wasting, deep tendon reflexes were normal and other lower limb was also normal. Systemic examination, abdomen was soft, non-distended. There was CNS examination, normal higher functions, no focal neurology decrease. Summarizing my case, 30-year-old gentleman presenting with a swelling of size 80 to 5 cm over the posteromedial aspect of the lower thigh for 6 months with rapid increase in size for last 1 month and associated with dilating pain. History of similar swelling at the same site 2 years back for which surgery and radiotherapy was done. On examination, swelling is firm in consistency, smooth surface and with possible involvement of muscles in the medial compartment. No palpable regional lymphadenopathy, no other clinical signs of neurovascular deficit in the left lower limb or any evidence of distant metastasis. My professional diagnosis is recurrent soft tissue sarcoma of the left thigh, clinical staging T2 N0 MX. By staging, we cannot do the correct staging. We can do it only after histological grading. Thank you.
Thank you. Examiners, please.
So your case appears to be a recurrent soft tissue sarcoma, isn't it? Did you have access to the histological examination of the previous surgeries and all? Was there any documentation presented to you?
Yes.
Yes, what was that?
The previous slides were showing a case of synovial sarcoma.
Synovial sarcoma. Okay, great. I think biopsies must have been done in this case. Twice he has been operated.
Yes, sir.
So records were available to you?
Yes, sir. High grade synovial sarcoma.
High grade.
Both times.
Yes, sir.
Right. Yes. So now it's a recurrent one. What do you think? Why it has recurred? It has been operated twice, but still it has recurred.
Soft tissue sarcoma is an aggressive tumor, and we should do a proper wide local incision away from the pseudocapsule. Then only we will be getting rid of the recurrence.
But basically you have inquired about trauma. What is the importance of trauma in cases of complications?
In trivial trauma may gain attention of the patient with this site of the swelling. Also, scar marks is also a cause, it is an etiology for superficial scar.
What is myositis?
Myositis ossificans is a conversion of muscle into bone. It is usually seen after trauma, usually when we are massaging the area after the trauma.
What are the other risk factors for soft tissue sarcoma?
Soft tissue sarcoma, ionizing radiations, childhood radiation, different
Maybe childhood radiation or radiation. What is
environmental factors, chemicals like polyvinyl chloride,
PVC? Okay, what is
thoracotrophs,
Thoracotrophs? Nobody uses nowadays. What is
dioxin, arsenic.
anabolic steroids, polypeptide juice. Any other risk factor?
Immunosuppression,
Okay.
anti-serum capsules are common.
Any
Viral etiology can be seen.
any genetic or any hereditary
syndrome, NF1,
and you have inquired about multiple swelling. Suppose a patient of neurofibromatosis, if they develop soft tissue sarcoma, what type of soft tissue sarcoma are more commonly developed?
malignant, peripheral nerve tumor,
Any other syndrome?
lymphoma is similar.
What soft tissue sarcomas are more commonly prominent?
Leiomyosarcomas,
Maybe anything else? Rhabdomyosarcoma, different differentiated sarcoma. Any other hereditary syndrome?
Gardner syndrome,
So it's a synovial cell sarcoma. Do you think that only these patients will require only radiotherapy? How do you decide that what kind of radiotherapy should be given in cases of soft tissue?
depending on the size of the tumor.
What is size? But size is not the only criteria. Yes, size is a good criteria, but as far as the metastatic potential or the numeric behavior is concerned, what is the most important factor?
Grade.
Grade. How do you grade? Which system do you follow to grade the soft tissue?
FNLCC
What
grade,
is FNC, LCC?
French,
Yeah, it's a French terminology, but if you have to say it in English, how would you term this FNC, LCC?
French National,
French Federation of Cancer Systems Sarcoma. Okay, so how do you grade?
grading is based on mitotic count, tumor
Okay, what is
differentiation,
mitotic count?
tumor differentiation,
Tumor differentiation,
and necrosis,
extent.
extent of necrosis. If the
One more point about the nucleus. Cellular nucleus anesthesia.
But you have different grading system, but as far as I can remember, as per this French system, you have three.
How many points are given to your tumor differentiation? How many points are given to necrosis?
necrosis, if there is no necrosis, 0 points is given, and if the necrosis is less than 50%,
Necrosis is 2 points, and the other two have 3
3
points.
points.
It depends if the necrosis, extent of necrosis.
Less than
50, 50 is the landmark. Below
Similarly,
50.
mitotic counts are different.
Mitotic count 0 to 10 to 19.
And in your staging, yes, you have rightly mentioned that you cannot comment on the grade of it. But you should comment whether it's a superficial or deep tumor, because now we talk in terms of A and B, apart from T1 and T2. So what is A and what is B?
A is violating the compartment.
No, it is not about the compartment, it is about the location of the tumor. Whether it is lying deep to the superficial or whether it is lying superficial to the deep. If it is lying deep to it, then probably it's a B. If it is lying superficial to it, it's A. It's 8th edition AGCC. In 8th edition AGCC, they have subdivided into A and B. In 7th edition, they were not talking about.
Coming to the case itself, you said that patient had undergone surgery and radiotherapy earlier.
Yes.
Do you think this radiotherapy could be a cause of recurrence?
Radiotherapy usually have a long latency, and it will only
So what is the usual time following radiotherapy when patients develop the sarcomas?
10 minutes.
Usually 10 years.
Can you name any disease condition in which after chemotherapy or radiotherapy the chances of sarcomas are very strong?
Radiotherapy to lymphomas.
Cases of retinoblastoma, okay, chances of sarcomas is very high. You also talked about the wide local margin that probably it was not achieved in this case, and probably this could be the reason why the patient has landed up with recurrence. So So in the present era, if we have to talk about the margin, and you also talk about the solo cancer. So how much margin we should take in soft tissue? Because in limb sarcomas now we put more emphasis in preserving the limb, isn't it? So how much margin is that?
Margin actually depending on the grade and the involvement of the nearby structures.
For high.
For a high grade, it should have at least 2 centimeters. But
It's 1 centimeter.
I'll just come back to that before some other issues. Some other issues, as Dr. Nobel has already pointed out, there are some graphs, we're not going to criticize the previous object. To me, 2 parallel incisions, 1 centimeter apart, is not what is normally being practiced in soft tissue. What are the principles of putting incisions?
in expect to be the incision should be longitudinal. And it should also include the previous bio.
So the second operation should have included the first scar. Or if the biopsy has been done earlier, other principles of putting a scar, incision. Not in this patient, the patient comes to you for the first time and you have open biopsy. Do you do an open biopsy in soft tissues? Normally?
Yes.
First we are doing a coronary
biopsy, and if it is not sufficient, we will go for an
So
incision.
if you are supposed to do a biopsy, what are the principles? It's longitudinal. It should include the previous scar, the point at which you will take it.
Biopsy should be taken from the apex of the tumor, and the and it has the highest growth.
What are your concerns because they have areas of
Yeah, you should avoid areas of necrosis. Number 1. Then next is necrosis of the tissue will come later on, which I will come back to. Next is
Immediate biopsy is better.
right there. Okay. When you have open biopsy, the flap should not be raised.
And
Good hemostasis should be there.
And there should not be any drain place.
Preferably no drains. These are the guidelines. Okay. So there are 2 incisions here. That is probably one of the criteria. One of the failures. Now coming back to the extent of incision. What are the different types of tissues are for the incision?
By limb preservers, we can go into incision, which is the most preferred.
There were different types of incisions. Things are lesion,
Marginal incision,
compartmental incision, wide profile. Have you heard about the principle called the Kawaguchi principle, which will answer the questions that they want? What is Kawaguchi's principle?
according to Kawaguchi principle, we are doing intra-compartmental.
No. The excision of the tumor, the extent of the excision of the tumor, previously thought to be a one tissue plane above that, is now restricted by natural barriers. Natural barriers are periosteum, perineum, adventitia of the vessel, all those things. So that is the Kawaguchi's principle. Coming back to Sir's question, whether radiotherapy alone would have been sufficient or not is $1 million question. And what is that motive to decide what adjuvant treatment or what treatment is to be given to soft tissue sarcoma?
Soft tissue sarcoma, adjuvant treatment, chemotherapy can be given depending on the histological type. For example,
Almost always you do an IEC in immunohistochemistry, isn't it? What is that what you want to do in the immunohistochemistry?
we are looking for markers from where the tumor is arising, markers like desmin.
Basically, there are 2 cells of origin in a soft tissue sarcoma. One is spindle cell syndrome, and second is round cell syndrome. You are basically looking at these two steps. If it is round cell syndrome, it is basically chemotherapy that is your treatment, whereas in spindle cell syndrome, surgery will take over. So that's the basic principle of treatment. All these other classifications will ultimately come, but basically, this is the thing that is in your mind that you are going to do. Chemotherapy. There are many tumors which are only given chemotherapy, right? Only chemotherapy. You don't use cells.
Which requires like
Sarcoma.
soft tissue, sir. Soft tissue, sir.
Ewing sarcoma, correct.
Ewing's and rhabdomas, some. Coming back to something else, let us look at the current staging system. You talked about T to some extent. So how many T's are there? 5, 10, 15, more than 15. Fine. Okay. N0 and N1. N1, lymphatic metastasis, lymph node metastasis in sarcomas. Tell me a few sarcomas where you will have lymph node metastasis. Which type? Okay. Next. Sarcoma sarcoma.
Epithelioid sarcoma, angiosarcoma, synovial sarcoma, undifferentiated sarcoma.
Classical would be what you started with. Anyway, okay, angiosarcomas are also known to be lymph node metastasis. Now, regarding what is, so great, we have talked about at some length. So tell me how a lymph node changes the staging.
When it is N1, it is going to.
What is the importance of, you have got a lung metastasis and you have got a lymph node.
Both are same stage.
Both are same stage. Both will put the patient in stage 4.
Yes.
Right? Okay. So importance of that is the lymph node will also put it in stage 4 as well as a lung metastasis. So how do you work up a patient of recurrent sarcoma for your management? What would be your work up?
First, we have to confirm the diagnosis, then stage the disease, then plan for the treatment and the investigations we need for the treatment.
Sure. Because from that,
Confirming diagnosis, we can, as an extension of the clinical examination, we can do diagnosis scan.
how do you know, this patient was under follow-up, wasn't he? I mean, he had surgery for sarcoma and that also 2 years back. So, how do you follow up a patient of sarcoma?
Follow after surgery, for the initial 2 years, it should be 3 monthly, and
Now, what are the things that have to be done in follow-up?
physical examination should be done, and if there and CT for MRI should be done for extremities. If there is
Radiation exposure, we have already talked about and its potential of implications on human health. So, radiation we will do as little as possible. So, ultrasound follow-up will do. Chest X-ray is important. And in cases of suspicion, you will do an MRI. Right. Okay. So, you will do chest X-ray and all these tests. So, this patient somehow probably escaped the network of follow-up. So, now that he is here, what investigations will you do?
we can do an FNAC.
Not can do, what will you do?
I will go for an FNAC.
FNAC first, before imaging.
Imaging. I will prefer. I will first able to go with an MRI of the extremity.
Right. So you do an MRI. Specifically, what are you worried about?
The involvement of the adjacent structures, any critical structures like nerve, vessel, or bone is involved.
What nerve is likely to be involved in a posterolateral, you said, posteromedial?
Yes.
What nerve is likely to be involved?
Obturator nerve.
compartment.
Lower thigh.
You also said the patient does not have any muscle weakness, or what muscles did you test?
So, all the lower limb muscles were examined. And
No, specifically which muscles were you interested in?
the medial compartment of the thigh. Swelling is in the left lower thigh, involving the posteromedial aspect, involving 40% of the circumference.
So what are you going to do? What are you going to do now with this data?
I will go ahead with an FNAC and confirm the diagnosis.
FNAC will only say malignancy. The expression of the tumor might be a little change in IHC. So you need it coordinated. Do you work with this patient at this
If the size of the tumor is
your patient? It's 6 into 8 into
and if the IAC is showing sarcoma or rhabdomyosarcoma, I will give a preoperative neoadjuvant chemotherapy.
Do you think that you need to stage this right now?
Yes.
How do you stage it right now?
Stage can be done with
Biopsy is the part of the stage where you get necrosis, differentiation, other than that,
CT scan.
what are you're very keen on doing a CT scan on every follow-up like there was no disease. Now when a disease is there, why are you so hesitant to do a CT scan? That's a basic minimum investigation. It's right. So there is no metastasis. Let's imagine that there is no metastasis.
And we will go for an ultrasound of the abdomen also. After staging the disease,
when would you like to do which kind of sarcoma you would like to do a bone scan? Which sarcoma has more potential to metastasize into the bones? Most of them metastasize to which, but which one metastasizes to the bone? Yes, angiosarcoma.
And you have to see the bone marrow. Certain sarcomas go into bone marrow. What is the estimation in those cases? Which sarcomas go to bone marrow?
Yesterday also we have discussed when the mandible is involved, you do a CT and marrow is involved in case of what MRI. Okay.
So, you have staged the disease and on CT scans, it shows multiple events. Recurrent sarcoma with multiple events.
there is a single metastasis. We can do a metastatic
So, if there is no absence of the test of the can do this effectively
The question is, you have done a CT and the CT shows a single metastasis. You would do a metastasis first or make the tumor first? Because in course of time other metastasis might appear. So you don't embark on metastasis unless you finish your primary treatment. Then you image and see whether there is an activity. Some of the metastasis might even disappear. It has to be biologically active to See, it's just like the chronic malignancy. You don't get into shadows and treatment. You have to do a metabolic analysis of the tumor is active, and then do surgery. Isn't it? So you first treat the primary. So we will treat the primary.
Multidisciplinary teams to be formed with certain oncologists, radiologists, pathologists, and plastic surgeons. Then preoperative investigations for surgery should be done. And
The bone has been put in your coat.
It's a more than 5 centimeter cervical cell sarcoma height. What
Recurrent.
upfront surgery.
It's recurrent.
And high grade are very important.
5 to 10 centimeter high grade cervical cell. What?
wide localization of the
Upfront white to magnetic.
surgery is the upfront treatment.
For a 10 centimeter, the guidelines are a little high grade.
You are talking about
Some adjuvant or
So essentially here is a recurrent disease, massive disease, aggressive disease. Do you think that a local treatment alone would suffice? Number one. Number two, is there any modality to which the patient is not exposed yet, according to you? Has this patient been given chemotherapy? Would you like to consider?
Yes, the tumor size is more than 10 centimeters.
That's what I must.
So neoadjuvant chemotherapy can be given.
So your extent of surgery in cases of cervical sarcoma will be only white localization or anything else. Any other precautions you would like to combine in case of cervical sarcoma?
What is the general aggressiveness of synovial sarcoma?
It's an aggressive.
Very aggressive. Very aggressive. In that background, would you like to answer the question?
I will go with a limb sparing surgery. I will try to avoid the amputation and get maximum margin of 5 centimeter.
Will you do anything to the lymph nodes if you have a group of lymph nodes? Will you go for any sort of lymph node dissection in cases of cervical sarcoma? Have what propensity to involve in lymph node dissection or MRI lymph node dissection?
clinical examination and any imaging can lead to the diagnosis of lymph node metastasis in such cases. Especially, what are the criteria? Clinically as well as imaging. That a lymph node appears to be metastatic. Okay.
So any question of sentinel biopsies?
Sentinel, but the trials are not sure.
So I am going to ask you all the controversial questions now. Sentinel node biopsy in sarcoma, needed, not needed? Not proved, conclusively. So you have to go by clinical means, number one. Number two is, what is next generation sequencing? Sarcoma, all the development is in this, what I am going to talk about now.
Genetic sequencing of the CA. 67 genes are particularly involved.
What is that called? That panel?
Since
SINSAR. Good, very good. So you have to look at sarcomas differently now at the molecular level. Why is it important to know sarcomas at the molecular level and look at the genetic mutations which create a driving problem?
so tissue sarcoma is a rare tumor, and most of the pathologists cannot delineate the different types of tissue
So
sarcoma.
diagnosis, the molecular testing gives you a firm diagnosis. So number one. Number two, molecular testing also helps you to
Therapy.
exactly choose therapy. and then obviously the possibility of future targeted therapy. So 3 possibilities. How does it help you to choose therapy?
If the particular translocation of gene
It helps you to choose the chemotherapy that you are going to give. So it helps in many ways. So you need to think about molecular testing of your sarcomas. That is done. So in this recurrent soft tissue sarcoma, how difficult is the dissection going to be? How are you going to excise it? Normally, in a sarcoma, when you excise, the path of least resistance is the path you should follow.
Yes. But in recurrent
No. Should you follow the path of least resistance in a case of sarcoma?
it is usually compartment specific. It does not violate the compartments.
What is the path of least resistance in a case of sarcoma? What is it actually? It's very simple. You cut and then you very easily get a plane. And what is that plane?
Sir, is primarily talking about the pseudocapsule. We tend to enter into the pseudocapsule, and that is not the excision, that is inhibition.
The path of least resistance is the path of the plane of the pseudocapsule. So you should never get into that. You should go beyond that. How do you decide that? Clinically, is it okay at the operation? You find induration. You decide this is up to this is tumor. Is this how you decide how much to excise in sarcomas, or is there a better method?
For extremely sarcoma, we can go with the post-section also.
No. You have to look at the preoperative imaging. That is most important because that tells you what is likely to be involved. You need to plan your surgery accordingly. Okay, because operative decisions like sarcoma is extended up to here may be very fallacious. So what do you do if it is very close to a nerve, like in this case?
If it is affecting a nerve, there is no problem for excision. We can excise the epineuron of the nerve. But if there is nerve involvement, we should excise the nerve also. Sufficient margin.
Excision of common peritoneal nerve will give rise to quite significant disabilities, isn't it?
Yes.
Right. What is the fixed to the femur?
Fixed to femur.
Bone.
If there is involvement of any two vital structures like bone, nerve, or vessel, then we should go ahead with amputation.
So if it is averting a bone, just near the bone, close to the bone, what are the methods of excision? Like in nerves you said. What about the plans with blood vessels? If it is close to a blood vessel, what do you do? Obviously you can't have that wide excision, that margin you cannot keep, but what would you do in that case?
The diminution of the blood vessel can be taken, and in the case of bone, the periostin can be taken.
Right.
Instead of saying that two or more structure is involved, you better say that despite all the efforts, if you cannot preserve the functional limb, then only two. Because if the vessels are involved, you can cut or you can put a graft. So many options are there, but better say if the function limb cannot be achieved, then we may do one. Any recent advancement in locally advanced soft tissue sarcoma of extremities as far as the method of delivering this chemotherapeutic agents are concerned. Any way of
Leaving chemotherapeutic therapy can be given. Isolated lymphodepletion therapy can be given.
It is hypertherapy. What medicine, what chemotherapy is given through isolated lymphodepletion?
Nitroplan, luminefrosphorus,
This patient, is there a role for an amputation, or what are the indications to do an amputation in a subject?
If we cannot do an intracervical surgery because of neurovascular involvement, even after doing the neoadjuvant chemotherapy, we can go ahead with amputation.
Extension of what he has said. A useless limb disability, and that is going to stand you can. Now, this patient is already irradiated, isn't it?
Yes, sir.
Can you think in terms of any form of radiation?
with radiotherapy can even because there is very low dose of energy and there is no surrounding damage.
Probably practical because principle of IMRT is also an external IMRT. You are only going to be at a focused area, and the effect of the penumbra is going to be much less than an IMRT. So you preferably convert this into a practical.
Indications of post-operative radiotherapy.
If the size of the tumor is more than 5 centimeter, it is a high-grade tumor and it is a recurrent tumor, then you will go with radiotherapy post-operative.
Or less than 5 centimeter, the margin is less than 1 centimeter or
More than
margin, where the resection is not very good. You also inquired about the CNS symptoms in your sarcoma patient and where no CNS. Can you name the sarcoma which has got propensity to size of brain?
Alveolar sarcoma.
Alveolar sarcoma, what are we use the type of problem?
Alveolar sarcoma.
What is the common site of? I'm not talking about head and neck, I'm talking about CNS. Brain metastasis. Yes, alveolar sarcomas are common in head and neck region and in the urogenital. I'm talking about CNS metastasis. It is common in clear cell sarcomas and angiomas.
Okay, thank you. Thank you so much.
Thank you, Dr. Cherry John. Now I would like to call upon stage Dr. Niti Sahai, Nalanda Medical College, Patna, for a presentation on liver mass. And the paneling will be done by Dr. Sanjay Debakshi from Kolkata, Dr. Nitesh Kumar from Patna, Dr. Shivajyoti Ghosh from Kolkata, and Dr. Sunil Kumar from Jamshedpur.
Can I request Dr. Sunil to please? Dr. Sunil.
Good morning everyone. I am Dr. Niti Sahai, postgraduate student from Nalanda Medical College and Hospital, and I am here to present a case on liver mass. So my patient was a 70-year-old lady, a homemaker, resides in Aurangabad, Bihar. She came to us with a complaint of loss of appetite for 2 months, abdominal distension for 1 month, passage of black stools for 1 month, and pain right upper quadrant of abdomen for 15 days. My patient was apparently well 2 months back. Then she developed loss of appetite, which was gradual and progressive. About a month ago, she noticed abdominal distension and fullness. This was not related to food intake or vomiting. This distension increased gradually over the days. Patient also complained of pain in the right upper quadrant of abdomen for the last 15 days, which was insidious in onset, dull in nature, continuous, not related to food intake, non-radiating, and not associated with vomiting. There was history of passing black stools for 1 month. There was history of early satiety. There was a history of weight loss of about 8 kgs over the past 2 months. There was no history of nausea or vomiting, no history of jaundice or dysphagia or bleeding per rectum or any history of alteration in bowel habits. She did not have any similar complaint in the past. She did not have any previous surgery in the past, and she was not a known case of hypertension, diabetes mellitus or tuberculosis. There was no history of any major illness in the family. My patient consumed vegetarian diet. She had a loss of appetite. Although the bowel and bladder habits of normal, there was melena present. There was no history of tobacco or alcohol consumption. The patient was a postmenopausal lady who had her menarche at the age of 13 years. She used to have regular cycles and had her menopause at 50 years of age. Coming to the general examination, the patient was examined in a well-lit room after proper consent. She was conscious, oriented to time, place and person. She was poorly built and looked cachectic. Her BMI was 15. Pallor was present. There was no icterus, cyanosis or clubbing. But bipedal pitting edema was present. Left supraclavicular lymph nodes were palpable. Karnofsky's performance score was 70. Her vitals were 90 beats per minute, good in volume, regular rhythm measured in the right radial artery. Her blood pressure was 110/70 millimeters of mercury in right brachial artery in supine position. Respiratory rate was 20 per minute and she was afebrile. Coming to the per abdominal examination, on inspection the abdomen appeared distended asymmetrically. The right hypochondrium was more distended. Umbilicus was central and everted. Right hypochondrium fullness was noted. A mass was also seen in the epigastric region, 2 centimeters left of midline and 2 centimeters below the costal margin. The flanks appeared full. All quadrants of abdomen moved corresponding to respiration. There was no visible peristalsis. Hernial orifices and external genitalia was normal. Coming to palpation, the liver was enlarged up to 12 centimeters below the costal margin and slightly tender. 2 masses were palpated over the lower aspect of the liver. Both were 3 by 3 centimeter in size, hard in consistency and nodular. The inferior margin of liver could be palpated below these nodules. Another mass was palpated in the epigastric region, 2 centimeters below the costal margin. It was 7 by 5 centimeter in size, non-tender, mobile side to side, globular in shape, hard in consistency, with well-defined margins, and it moved with respiration. On straight leg raising test, this epigastric mass became less prominent. On percussion, shifting dullness was present. All masses were dull on percussion, and the liver span was 20 centimeters. On auscultation, normal bowel sounds were heard. On per-rectal examination, the mucosa was normal. There was no growth present, but there was black-colored stool on the examining finger. Coming to examination of the left supraclavicular fossa, there was obliteration of space between the 2 heads of sternocleidomastoid muscle on the left side. On turning the face towards the right side, a swelling of 3 by 2 centimeter was noted in the left supraclavicular fossa between the 2 heads of sternocleidomastoid muscle. The systemic examination was within the normal limit. Coming to the summary of the case, my patient was a 70-year-old lady who presented with abdominal distension and pain in the right upper quadrant of abdomen. She also had complaints of loss of appetite, passage of black-colored stools, and significant weight loss. On examination of the liver, the liver was found to be enlarged, and 2 hard nodular masses were palpated over the lower aspect of liver. Another hard, dull nodular mass was noted in the epigastric region. The left supraclavicular lymph node enlargement was present. Based on this clinical history and examination, I conclude that this was a case of a 70-year-old lady with secondary tumor in the liver and primary in the stomach.
Thank you for the examination.
That's sort of the history. Should you have also taken a drug history? I noticed that there was significant signs of promotion.
Yes, sir. Iron tablets.
Or long-standing history of NSAIDs causing a problem. Because the patient presented with black stool.
Yes.
Black-colored stool. The second thing is, you said that the liver was enlarged. Did you actually percuss on the upper border of liver dullness?
Yes.
And where was that? I think it's important to distinguish between visceroptosis and enlargement to define them. You want to establish the fact that this is the liver which was enlarged.
You mentioned a number of negative results. Could you please explain?
So history. So I wanted to exclude nausea and vomiting just to exclude any obstructive features since the patient has distension of the abdomen. No history of jaundice to exclude any gallbladder involvement. No history of dysphagia to exclude any esophageal involvement since it's a secondary tumor to exclude the primaries. No history of bleeding by rectum and alteration in the bowel habits. I asked her to exclude primaries in the colon. Yes.
You mentioned there is no similar family history. Is there family history which is responsible for causing liver cancer?
Sir, I said there is no.
Is there any inherited disease causing liver cancer?
Hepatitis B is a risk factor family members.
But you never asked anything regarding IV drug use, history of blood transfusion. There is Wilson's disease. Was it hepatico-lenticular degeneration, that are cirrhotic-like picture, and then hepatocellular carcinoma. And there one is alpha-1 antitrypsin deficiency.
You have described two masses in the abdomen.
So 3 masses. So 2 nodules over the liver and another.
Basically it's the liver,
Yes.
and the second one, and liver with 2 nodules.
Yes.
And the second one,
Epigastric lesion.
which is different from liver.
Yes.
How did you differentiate between these two masses when you said the epigastric mass is also moving well with respiration? Could you insinuate your finger anywhere? Why would it not be just another liver?
So it was mobile from left to right.
There was a differential.
Yes, sir. That was not. I could not insinuate my finger over the upper border of the liver.
Which makes it more prone to be a liver.
Yes.
Or a conglomerate mass. Usually see a stomach of this big nature if you have one.
Yes.
You see a conglomerate mass where early indication to the left lobe of the liver locally is going to come. So that's 7 into 8 centimeter, 8 centimeter large mass. Right. Before I leave it to Dr. Sanjay, let's say visceroptosis, what is the clinical sign that you will use to say that it's visceroptosis?
Sir,
What's the clinical method to say that this is visceroptosis?
the liver
He
span.
asked, how do you diagnose visceroptosis?
So we look for the liver span from the upper border of the liver and the lower border of the liver, and usually the upper border is in the 5th intercostal. It starts from the 5th intercostal space.
So in thin lead individuals, you stand behind the patient and ask to breathe, and you have the liver coming low down with that upper. This is called which sign? It's called the Glenard sign. Glenard sign.
The other thing is that you define this fullness of the right hypochondria.
Yes.
How much is the right hypochondria? You've got an 8 centimeter liver.
Yes.
Do you think?
So it's extended into the right lumbar region.
So just be a bit cautious about when you use that term right hypochondrium. Right hypochondrium is a very small space. So it's probably a better idea to say right upper quadrant. This sort of a situation.
Same question. How big is the right hypochondria? Can you show us that it is this big? Very basic level question.
So it extends from the costal margin up
It's
to
not more than the surface. Right on either side. So that is the area of right hypochondria that is available for calculation.
The other thing that you have said in your clinical examination is that in a patient who has got shifting diabetes, you said that you failed to elicit a fluid fill. You don't elicit a fluid fill unless and until it becomes possible only when this shifting dullness disappears.
Yes, sir.
So the lowest level is puddle sign, which no longer typically gets done. Then the second level is going to be shifting dullness. The third will be most fluid, you get a horseshoe dullness. And finally, it will be a fluid. Right?
Also, with such a large liver, if you're eliciting shifting dullness, you said shifting dullness
Yes.
was possible.
Yes.
It's important to do it on the left side. It's sometimes very difficult to find an adequate resonance base because of the liver on the right side. So you need to be cautious about your presentation. Because then you're going to be asked questions like this.
Now, what is melena?
So melena is passage of black stools, which is malodorous and sticks to the pan. I mean the characteristic of the stool.
How does it occur?
So it is bleeding in the upper GI tract.
What is upper GI?
So up to the upper part, the upper half of the duodenum.
Is there upper GI? How do you define upper GI or do you define lower GI? Very fundamental MBBS level question.
So the Treats ligament. The Treats
So
ligament.
anything above the Treats ligament is upper GI, right? So there the bleeding acid rheumatic comes in because the stomach acid, hydrochloric acid, converts the hemoglobin into acid rheumatic, and that's why it gets passed out.
Suppose you have bleeding in a patient with obstructive jaundice. Is the stool still black?
So it will be clay color.
With reference to a tumor which is going to slough as inflammatory carcinoma and the blood has come. That is, you should just wait the perspective. Somebody has told about melena, ligament of treaty. Suddenly an examiner asks you, is that the same in my obstructive jaundice? You need to take a cue from there.
Said the Winchell's gland is positive. So this is a repeat question I think to discuss yesterday. So can you just tell us how the cancer cells travel to that?
So from the cisterna pili, so it ascends up on the right side till P4 level. It goes, then it goes on the left side to the left thoracic duct, sir, and then it drains. So the thoracic duct, and then it drains at the junction of left internal jugular artery and the left subclavian artery, subclavian vein. Sorry.
So which is of the diaphragm it enters in the thorax?
It travels through the aorta, through the aortic hiatus.
Now, we'll stick to your case. How are you going to proceed on that?
Sir, I'll start with an ultrasound to confirm my diagnosis, just to know the origin of the tumor and the presence or absence of the tumor. Then I'll go for a upper GI endoscopy to confirm the primary. Since the patient, I believe, also has ascites, I'll go for an ascitic tapping and look for malignant cells. She also has a left supraclavicular lymph node involvement, so I can go for an FNAC.
All these things will you do at once then?
I'll start with ultrasound.
Okay.
I'll confirm whether the primary is in the stomach or not. If it is in the primary, then I go for
Ultrasound will not tell you whether it's from the primary from the stomach or not. Ultrasound is a very poor investigation as far as GI tract, hollow viscous system is concerned. So you will only say that the liver is having nodules and liver is having, probably metastatic problems.
You said you will do an FNAC with the supraclavicular, that is fine. I'm trying to pick up cells from the fluid.
So to know whether there is a peritoneal metastasis
With a, you should understand that this index patient, you should also know how are you going to treat this patient? What is the stage of the disease? Suppose this patient is CA stomach with supraclavicular. What is the stage of the disease? With hepatic metastasis.
Stage 4.
Thus, another malignant cell synthesizing will alter the stage of the disease.
See, whenever you do an investigation, it must help you.
You understand the rationale of the question. The patient who has got already a supraclavicular,
yes,
and you do an FNAC and you establish malignancy and establish the stage for carcinoma of stomach, putting a needle into the abdomen and drawing in a cyclic fluid and say that there is malignancy. Does that in any way upstage or downstage the disease or alter the treatment? So it's not needed.
so first I improve her nutritional status. She was managed. I start with a high protein diet.
Do you think that it is possible? What is the goal of the treatment? Yes. Yeah, it is not a curable disease. First understand that. So what's your aim of treatment?
So palliation.
What is similar to palliation?
I'll start with the quality of life of the patient. I'll try to chemotherapy.
When you talk about palliation, at this point of time, is she suffering from anything? Except weight loss and loss of appetite. Does she suffer from anything?
So, extension of the abdominal extension.
She is bleeding.
Yes, sir.
She is bleeding.
Sir, I look for her, I get a CBC and look for a hemoglobin status.
That is 6 milligrams.
So then I ask for a blood transfusion. So tranexamic acid.
No. Answer my question. You give one PRBC, how much of hemoglobin improvement is expected?
So 1 gram per day.
Okay, so you have given 2, but the hemoglobin still continues to be 6. So she is bleeding. That's what sir has done. What are you going to do?
I go for an endoscopy.
Binding the patient.
So I go for an endoscopy.
So we have already done that.
Yes.
The address is confirmed.
Okay, sir.
Right? Yes. After 2, it still remains 6 or maybe it still goes up by another 0.5.
The question here is whether you need to initiate palliative chemotherapy or do something. Answer that.
Yes, I will initiate.
Before that, so you have clinically diagnosed the patient and you have done ultrasonography, right? And ultrasonography says that it has got 2 liver nodules, right? And clinically you have got two nodes and cycles.
Yes.
Would you like to do any further investigation, or on the basis of that investigation you plan your further treatment?
Sir, I would like to take a biopsy on endoscopy just to give a pathological confirmation, and then I can start.
Biopsy from where?
So we usually take 10 biopsies, endoscopic biopsies.
From the stomach?
Yes, from the stomach, from different sites in the stomach. And I confirm, I will get a pathological confirmation of the diagnosis, then I can start with the palliative management.
Are you going to stop your investigation at just endoscopic biopsy and then ultrasound? That's the question. Or would you like to do something more?
So I'll stop the pathological confirmation. If it comes out to be a stomach carcinoma, primary in the stomach, then I'll stop.
Very often we find that after the endoscopic biopsy has been done, right, you're waiting for the report and you find that the biopsy comes to be inconclusive.
Then
in this particular patient, it comes to be inconclusive, then what is to be done?
Sir, I'll go for a CT.
Now you see, we have already done an FNAC from the supraclavicular.
Yes.
CCT will not alter your diagnosis at this stage or will help you. CCT is not required here at all.
Yes.
So we have proved that it is an M1
Yes.
by getting a definition from the
Supracapital.
Yes, and it has told you that there is a chew and start.
Yes, sir.
So I think that will suffice regarding the pathological analysis.
So I'll start with the chemotherapy now. I'll start with chemotherapeutic agents such as 5-fluorouracil, epirubicin, and 5-fluorouracil, and there are also biological agents.
But then again, this patient might start bleeding. So you may have to do something as a salvage. In certain cases, you may be forced to go for surgery.
Yes.
In certain cases, that is what I mean. Maybe you have to do some more transfusions, make the patient somewhat ready. Maybe the patient may not be ideally fit. In that case,
So then I'll go for surgery. So I'll have to look for where the tumor is exactly, and depending on that, I will go for a gastrectomy.
we call that dissection of primary in certain cases.
Yes.
Right? May not be possible in most.
So, you've got to identify your problem. You're going to palliate the patient. And the only thing that requires palliation, she's not in pain, she's got mild abdominal distension, but the palliation, as everybody is pointing out, is the bleed. So, essentially, that's what Sir was saying. You try and do the resection, but sometimes that's not going to be possible. Isn't it?
Your palliation to stop bleeding can be of many nature, unless be conservative, be whatever that is there. You have non-operative methods also to control bleeding. Can you name something? Operation in these stages of patients are very, very unlikely, very unlikely that you cannot be able to do anything. So you
Endoscopic dilation.
and ulcerated that is having flow. Can you go beyond the lumen and do something?
Endomucosal resection.
Endomucosal
resection is for more technical.
So for the very low grade tumor, sir.
Not low grade.
Present in the mucosa, which is limited to the mucosa.
Exactly.
Exactly.
You endomucosal resection is for a very early carcinoma,
which you won't be able to feel as a separate lump. If you're feeling a separate lump,
so the traditional teaching is that when your stomach mass is parallel, it is very unlikely to be over. That's a general thing. Maybe you can get some of the ones. By and large, palpable stomach malignancy is normal. Right? So can you take the cue from what I said? Can you take the help of some other specialist?
you're saying that can you take the help of some other specialty? You mentioned radiology.
Can the radiologist come in your skill?
Localized chemotherapy.
We are only dealing with
Embolization. Chemoembolization.
No, why chemo? You are basically only trying to stop the bleeding, isn't it?
Yes.
Right. Just stop it.
Yes.
Just embolize.
So therapeutic embolization, we normally don't do it with other parts of the intestine because it necroses. So why are we so, everybody is agreeable to do it for the stomach? In other words, what's the blood supply of the stomach? How many ways?
So it has a rich blood supply from the celiac, from
What are the vessels?
so the common hepatic artery.
Come on, you are a postgraduate
left
student.
gastric. The left gastric artery drains the lesser curvature. On the right side, there is the right hepatic artery, which gives off a branch as a gastroduodenal artery, which supplies the lesser curvature.
Please name the gastroduodenal supplies only the drainage.
No, sir. There is also the epiploid artery,
Please
left and
name
right.
please name the vessels which supply the stomach. That's not complicated.
So the
He
left,
asked you from where it arises.
so the left gastric artery, the gastroduodenal artery, or so the left gastric artery,
If
the
there is a
left,
left gastric artery, you should have a right gastric artery.
yes,
Right or wrong?
yes,
Okay.
right gastric artery. The left epiploic artery, the
So
right.
there should be a right epiploic artery.
Yes, sir.
Right. Anything more? So you have covered now 4. Is there anything more?
Undecayed coming from one of the other branches of the celiac.
Short gastric. So those are the blessed. Right? Okay. No confusion. Left gastric is a branch of
It's a branch of the direct branch of the celiac.
how many branches are there?
The three. The sphenic artery, the right hepatic artery, and the left.
Right hepatic.
Sphenic artery, left gastric, and
Common, the common hepatic artery.
no, let's stop there. Otherwise, it will going to get confused. So the idea is you don't do an embolization in organs which have got only one artery, then done, because that organ gets exposed. Whereas in stomach, it is still possible because it has rich blood supply. Okay, this is something you palliate. Now this patient has got vomiting. How are you going to palliate?
So she has a vomiting. So first I'll manage the electrolytes.
Vomiting will not get managed by electrolytes. Consequences of vomiting will get corrected by electrolytes.
Yes.
There is a patient who has got an advanced malignancy, but persistent vomiting, she is unable to swallow. So unable to retain everything that she takes gets vomited. Can you tell me
Sir, I'll try to put in a rice tube.
what is achieved by putting a rice tube?
For nutrition.
So madam, the pylorus is obstructed and it is shut off. It is nothing is going to do with the duodenum.
I'll do a bilateral surgery, gastroduodenal.
Operating this lady would be nice. One of us will be interested in touching this lady.
Can you use your endoscope for any advantage?
Whenever there is a human which is narrow, can you
stenting?
One is stenting. Is there any other option? Not in stomach, but take probably in colon.
Jejunostomy.
I don't get into that. You will do a urinary stent here. So if it's colon, along with the stent, you also have the option of a laser temporary. Stomach.
Not a terrible road, it's too.
So it's that relieves the patient of the vomiting.
Not in this patient. Suppose the patient has had long-standing vomiting. You were talking of electrolyte abnormality. What electrolyte abnormality do you get in somebody who has a gastric outlet obstruction for long duration?
So, hypokalemic, hypochloremic metabolic alkalosis.
Hyponatremia?
Yes, a hyponatremic.
Protein?
Oh yes, there is hypoprotein.
Plenty of hypos around. Okay. What is the pH of urine?
6.8.
The question here is in this particular patient with a chronic gastric outlet obstruction,
So, aciduria, so there is acid.
what is it called?
So,
Paradoxical
paradoxical acid.
So when do you expect paradoxic acid urea? When do you expect paradoxic? And why? Why does paradoxic acid urea occur?
Sir, it starts, sir, due to vomiting and so there's loss of
Normally
potassium
there is
and
loss of
chloride.
H plus ions.
Yes, sir.
Only when?
Sir,
What is the normal?
The body wants to retain sodium.
You sure it's sodium? No, it's not. It is when potassium goes below 2. It is below that the heart work.
H ions are always combined with potassium ions in exchange. Body prefers always potassium.
Potassium next into hydrogen ions.
So there is a paradox. Right? Is potassium very good for you or bad for you?
So bad. High potassium is not
What will happen?
So high potassium will lead to tachycardia, ECG changes,
And finally,
T waves in the ECG, and
suppose you are
arrhythmia.
giving 20 millimoles of potassium as an IV injection. What will happen?
So tachycardia, arrhythmia, and ultimately death.
Something life-threatening happen.
Death occurs.
Yes.
Is it used in clinical practice, hypotassic urine, since the stomach is slipping out of our hands?
Used in surgery, hyperkalemia.
No. High potassium is it used in clinical practice ever?
No, sir.
It is used to stop the heart. When do you think that it will stop the heart?
Bypass surgeries.
Cardioplegia.
Yes, sir. Cardiopulmonary
They are all
bypass.
rich potassium.
Yes, sir.
How long this patient is going to survive?
So,
Regarding this clinical scenario,
so 6 to 8 months, even with
minimum
failure.
metastasis not more than 6 months.
Yes, sir.
So in course of time, what are the likely events or other symptoms of the patient?
So she may have a lung metastasis also over the period of time. She may complain of cough and hemoptysis. She already has severe
Pain.
yes, sir, due to the liver enlargement.
How do you find pain?
Severe pain radiating from the back.
Pain is not essentially because of the liver enlargement. It's partly yes, but then the pain of the customer stomach is for local retroperitoneal infiltration, isn't it?
I'm just going to paint a slightly different scenario. I know you for the stomach out here. In this case, the endoscopy was normal, there's no fluid, and there are multiple liver mets.
So endoscopy is normal and no fluid and multiple elements.
Scenario does not change.
Okay.
The site is.
The site is and endoscopy shows that the primary
Diagnosis is the same.
Same scenario. Only there is no fluid.
Okay, sir. So, it will still be the same management.
Okay, let me just take it back. You have chronic pain management. Let's look at it in different aspects. How do you manage a chronic pain?
Some morphine.
Straight.
Silent
What is
start with
the WHO pain management?
So step up.
What is that?
So first we start with NSAIDs.
You start with NSAIDs. Anybody? Step 1, level 1 pain management by WHO is just paracetamol.
Pain, acetaminophen, paracetamol.
And then what level do you give? 1 gram. You go up to 1 gram. Fourth, the last dose may be at 10 o'clock, not to wake up the patient. Next level.
So NSAID, peer and NSAID, diclofenac.
Yeah. So please read about morphine toxicity. Last stage. Those start with, you have one more step beyond that and non-opioid steroid. NSAID. So after that only you come with morphine. Right. And then what are the other options? Can you do something locally to alleviate pain?
particularly where you don't have ascites. With ascites, it makes it very difficult to know.
The dermal patches.
That is again, he has already told there is no ascites, so take the cue from there.
Can we use some needles?
Why do you have such intense back pain? This patient has intense back pain. Pain radiating from the back. Is there something you can block?
So nerve block.
Which nerve block?
Celiac structure.
Exactly, yes.
Exactly.
It's a celiac block. Right, it's a percutaneous celiac block under some guidance. Then you can't block blind. So it is almost always done under invasive guidance.
Vertical level. Under guidance, you do the vertical and block there.
It's okay, it's not a surgeon's job.
So anything else, suppose that this patient is educated. So other than the pain management, any other addition you should consider. These patients are usually what? Psychological counseling. So should be given some more education.
I think surgeons these days should also know about end of life care. I think that is also, for this patient, personally, I may be wrong, because she's coming from a very low socioeconomic strata. I probably may not like to start like chemotherapy for this patient. I would just be very conservative on this patient. But then I would be very keen on, taking the family and the patient towards the end of life. Have any idea about
End of life care, euthanasia.
No, not euthanasia. End of life care is not euthanasia.
Hospice care. Hospice care.
what is hospice?
What is it?
Hospice.
Yeah, it is a big coming up. It is a big coming up area in modern medical practice that you should prepare for the family as well as for the patient particularly to have a graceful death. That's also part of our job. It is not that we are only going to operate this patient. We have to see that they are made for it. And the patient as a human being is respected gracefully without. There is no point in trying to do a resuscitation of this patient So please, all of you, please read about life care. It is very important. I think the Ramanus was saying about this something which is important.
Yes, very good scenario. I think we should have prepared many of the IET people.
Exactly.
The scenario is very good. The scenario is very good and should have confined more towards IET.
Palliative factors. So personally, I would not like to do this. Okay, thank you very much.
Thank you, Dr. Neji, for her presentation.
One announcement to make. After this session, the results will be declared, and immediately after the result, will proceed for lunch. So everybody have your lunch and go. There are a lot of lunch, so please I request everybody have your lunch and go. We'll try to get the lunch after the results are over. Please.
Now I would like to call on stage our last participant, Dr. Sukanya Das from igims, Kolkata. She will be presenting on renal mass. And the paneling will be done by Dr. N.K. Jha, Dr. Prem Prakash, Dr. Utpal De, and Dr. Mrityunjay Mundu.
Good morning, everyone. I, Dr. Sukanya Das, second year junior resident at IPJMIA and Assistant Hospital, Kolkata. I'm here to present my case for renal mass. My patient, Mr. A.B., a 55-year-old gentleman, farmer by occupation, resident of Malda, West Bengal, was examined on 10th of August this year, and he had a chief complaints of discomfort in the right flank for the last 2 months and passage of blood and urine for the last 1.5 months. Patient was apparently well 2 months back when he complained of discomfort in the right flank, which was in serious onset, gradually progressive, continuous, dragging in nature, with no history of radiation. It was not related to micturition. It relieved temporarily on taking medications with no specific aggravating factor. There is also history of painless passage of blood and urine for the last 1.5 months. It was occasional, present throughout the stream of urine, uniformly mixed with urine, and gradually increasing in frequency. He also complains of intermittent passage of blood clots since the last 1 month, associated with pain which was colicky in nature, radiating from loin to loin during the episodes. There is no history of urinary hesitancy, urgency, or nocturia. There is no change in frequency of micturition. Patient also complains of malaise and lethargy. There is no history of unintentional significant weight loss, no history of fever, no history of cough, breathlessness, or hemoptysis. There is no history of low back pain or bone pain or yellowish discoloration of eyes or urine. There is no history of syncope, headache, seizures, or blurring of vision. There is no history of abdominal trauma. And there is no history of pedal edema or generalized body swelling. Moving on to the past history, you see there is history of 2 units of blood transfusion in the last 1 month. There is no history of similar episodes in the past. Patient is not a known diabetic or hypertensive. There is no history of major medical ailment or surgical intervention in the past. There is no history of any long-term medication used by the patient. And there is no history of pulmonary TB or contact with tuberculosis. The patient is married, has 2 children, and all of them are healthy. Appetite is reduced, sleep normal, bowel habits normal. There is no history of smoking or alcohol intake. Family history, there is no history of similar illness or malignancy in the family. Under treatment history, patient visited a local practitioner and received symptomatic treatment. But when his symptoms did not resolve, he attended a local hospital where he received 2 units of blood transfusion and was referred to a higher center for further evaluation. Patient has no allergy to any food or medications. Moving on to the physical examination. Under general survey, patient is conscious, alert, cooperative, well-oriented to time, place, and person. His performance status was Carnofsky 90 with a BMI 21.4 kg per meter square. His build was average. Pastries and gait were normal. His hydration and nutritional status were adequate. Decubitus of choice. Pallor was present, but icterus, cyanosis, clubbing, edema were absent. Neck veins were not engorged. Neck glands not palpable. They had a pulse of 86 per minute, regular, normal volume, no radial or radiofrequency they appreciated. He had a BP of 152 by 98 millimeters of mercury and a respiratory rate of 17 per minute. Temperature 98.6 degree Fahrenheit, and a Foley's catheter was found instead. On examination of abdomen, in inspection, abdomen was normal in shape, umbilicus was inverted and central in position. All quadrants were moving equally with respiration. There was no visible peristalsis or pulsatile movements seen. no visible scar, pigmentation or engorged vein seen. There was fullness that was seen in the light right flank region. No renal angle fullness, and external genitalia and hernial sites were normal. In palpation, temperature was normal in all quadrants, no superficial tenderness elicited, abdomen was soft, elastic with no guarding or rigidity. On deep palpation, a 8.5 centimeters lump was palpated in the right flank, which was bimanually palpable, palatable, mobile, firm in consistency, and moving with respiration. The lateral and the lower margins were palpable, but the medial and upper margins were not well palpable. The surface was irregular. There was no tenderness on deep palpation, no renal angle tenderness on either sides, no other organomegaly noted, Foley's catheter was non in situ, and external genitalia and rectal examination was within normal limits. On percussion, a resonant note was obtained on abdominal percussion. Upper border liver dullness noted in the 5th intercostal space. A dull note on the percussion was found over the lump. The right renal angle will reveal a dull note as well. There was no shifting dullness elicited. On auscultation, the bowel sounds were present in all quadrants. No adventitious sounds auscultated over the swelling. Since systemic examination, the respiratory, cardiovascular, central nervous system and musculoskeletal system were all within normal limits. So to summarize, a 55-year-old male patient presented with complaints of discomfort in his right flank for the last 2 months, which was continuous, gradually progressive, dragging in nature, relief temporarily on taking medications, with no specific aggravating factor. He also complains of intermittent episodes of passage of blood and urine present throughout the stream of urine and painless in nature, gradually increasing in frequency for the last 1.5 months. He also complains of occasional passage of dark red urine with passage of clots, not associated with colicky pain radiating from the loin to groin for the last 1 month. There is no history of fever or increased frequency of micturition, no history suggestive of distant metastasis. On examination, general survey was found to be essentially normal except presence of pallor and an incidentally found raised blood pressure levels. On examination of abdomen, the shape of abdomen and umbilicus were normal. Right flank fullness was noted. No engorged veins or scar over the abdomen, moving normally with respiration in all 4 quadrants. No visible peristalsis was seen. Right kidney was enlarged, measuring 8.5 centimeters, bimanually palpable and palatable. Lateral and lower margins of which were well palpable, but medial and upper margin not palpable. Surface irregular, consistency firm, moving with respiration. The swelling and right renal angle were found to be dull on percussion. No other mass or organomegaly was found. Examination of external genitalia normal, and rectal and other systemic examinations were within normal limits. So I would like to provisionally diagnose this as a case of right-sided renal swelling, probably renal cell carcinoma, in a 55-year-old male with no features of distant metastasis. Thank you.
Thank you. It's open for the examiners.
If you go back to your first slide, you said that the patient was having some discomfort. Can you characterize what do you mean by this discomfort?
So as explained by the patient, he had some heaviness and discomfort. I had asked particularly if he was experiencing any
But the
pain.
characteristics that you have described relates to pain, isn't it? So what is the distinction between discomfort and pain? Because if you say it's a renal swelling, if you say there's some discomfort, so that probably indicates a different etiology than what you have described.
See, so he basically complained of heaviness. So, and discomfort. So,
That is what I said. Okay, means you meant to say, did you mean to say it was pain?
so it was a dragging pain. It can be also said as dragging pain.
It's a dragging pain. So can you tell me the other causes of pain in case of a removal?
So, pertaining to malignancy, the pain can be due to causes like stretching of the capsule when the mass enlarges in size. It can be due to local infiltration into the peritus once it is enlarged. It can be due to hemorrhage or superadded infection. And it can be a clot polyp.
That's good.
Okay, sir, and you also described the word imagery. What is imagery?
which is, can be, it's passage of blood in urine. It can be microscopic or macroscopic. Microscopic is which is not visible to the unaided eye and more than 5 RBCs per high power beam.
Okay. Now, whatever you have described from your history, can you describe this hematuria into some other form? Or can you say hematuria in terms of some other term? Because you said that the patient was having hematuria throughout.
Yes. Glomerular and...
Do you know what is a terminal hematuria?
Yes,
What
sir,
is
yes.
proximal hematuria?
Yes, sir.
What is total hematuria?
Yes.
Can you tell me the cause?
Terminal is typically seen in bladder stone. Initial hematuria can be seen in urethral stones, and total can be seen in renal stones or in malignancy bladder.
You also mentioned about clots, isn't it? You also mentioned about clots. So can the shape of the clots that the patient pass, who has to, whether it is a gross hematuria or a hematuria which is not of that much amount?
I'm not sure what to say.
So if the patient has a gross hematuria, the clots have a different character. It's usually serpentine. Right? Now, because until the hematuria is small, then what happens? There is zero kinase in the urine. So that is also. So the clots are usually of irregulation, amorphous clots.
Yes. So, your provisional diagnosis is renal mass, probably renal carcinoma. So, what is renal triad? I think this presentation is fulfilling the renal triad.
Renal triad comprises of venous hematuria, then a right flank pain, and a right mass, renal.
So, do we have frank hematuria in all cases of renal cell carcinoma?
Hematuria is the most common complaint, but it is not necessary to be present in all
Not all,
cases.
not all. What is incident loma? Is it relation to renal mass? What is incident loma?
So nowadays with extensive imaging procedures, we have most of the cases of renal cell carcinomas and other renal lumps are being diagnosed on imaging rather than the patient presenting with symptoms.
So incidentally investigated for other conditions,
Other condition, yes.
mass was found.
Yes.
That is one incident loma. This mass is of which side?
So 8 by 5 centimeters.
Is it palatable?
Yes, it is valid.
What is the cause of palatability?
So the main cause is that it is the kidney is attached by the means of a pedicle, and so when we palpated.
And explain two conditions. Move with respiration and palatability.
First, let's take palatability. Prerequisites for palatability. One, you said it needs an attachment. I do agree that it has to have an attachment or a fulcrum to move around.
Yes.
Is there any other, there are so many organs which have
It should not be fixed to it, like not a lot of attachments or ligaments should be attached to that.
Be free to move.
Yes.
So that it moves freely in the Zerotus capsule. So similarly, any organ which is going to be free to move and has got an attachment with the nostril alone will be allowed.
Why film? Why in the capsule? Why the film? What is there that it makes it really move inside the capsule?
Why will the lump move freely in case it is allowed? That is what he is asking.
Slightly different. He is asking, why is it free to move in the Zerotus capsule? What are the other condensers? What are the other condensers in the Zerotus capsule? You've seen an nephrectomy being done. Forget about it. Forget about it. It's a space where you have got, lot of fat. Yeah, very fat. Okay, fine.
That's good to know about the fat because treatment matters. When treatment matters. I mentioned in some blurring of vision. No history of blurring of vision in case of renal mass. Is it significant?
So So actually I was trying to eliminate any CNS spread of the disease, so this is part of that.
I would have thought that you would have given a little more brilliant answer. CNS metastasis, how often you see in a renal cell carcinoma?
It's very uncommon.
Very uncommon. Did you have any other reason to think that the patient can have blowouts and all those things? A renal mass?
I received thrombus.
No. You said that she's recently detected to have hypertension.
Yes, sir.
Right. So you could have answered, see, even if you have not known, you could have been brilliant to answer that way. You know, instead of trying to say that brain metastasis in renal cell carcinoma, we probably may not have seen it practice.
This patient had blood transfusion before coming to you.
Yes.
I really suspect that he must have had an ultrasound before coming to your hospital. My point is, by palpatory finding, could you make the diagnosis of renal mass or something else had come to your mind before that? Where is the lower limit of the mass anteriorly? Normally, which part of the right kidney is palpable?
No, normally it is not palpable, but so the lower margin can be palpated. If, I mean, in
Which
this
part?
case,
Which part? Which part of the right kidney? Just the lower kidney, if at all it is possible, right? That is number one. Number two, I could have made a diagnosis of bowel mass also, such a low-lying lump. You had mentioned loss of appetite for bowel symptoms. Any other symptoms, bowel symptoms?
no, there was no change in bowel habits or any features of intestinal obstruction. In weight loss is pretty common in GI malignancy. That is also not there in this patient. We might found on examination, we might find on percussion tympanic note to be found.
Okay, that doesn't rule out the bowel mass also. But one more point, you must be very clear about bimanual, palpable and palpable. Are they the same or they are different?
Sir, they're different, sir. Because a mass can be bimanually palpable but not necessarily palatable. As it was discussed before, for it to be palatable, there has to be space for it to move. If it is a large mass and I'm able to palpate it even without pressing my hands, there is no space for the lump to move, so it will be not palatable.
Okay. How do you clinically differentiate the mass arising from the retroperitoneal structure from the intraperitoneal structure and the mass arising from the right shoulder?
So we have the leg raising or head raising test. In case of a parietal wall mass, it will become more prominent in such cases, and a mass which is intraperitoneal will become less prominent. And to differentiate between intraperitoneal and retroperitoneal, we have asked the patient to for knee chest position. Elbow knee,
Not to be done.
not to be done, yes, sir.
What is lateral tilt test? Lateral tilt test. Lateral tilt test. Lateral means lateral, tilt means tilt. You tilt the patient laterally and see what the movement and where the position is seen. Simple, isn't it? It's only an explanation of the literature, that's nothing else. Can you find such type of renal lump, such a big lump in other position? And what will be the difference?
Unascended kidney.
Ectopic kidney.
Yes.
Understood. So what is the basic arrangement difference in the renal pelvis in the ectopic kidney and the normal kidney? What is the relation of renal pelvis, renal pelvis and renal artery? Is there any difference?
So normally it goes in the order vein, artery, and ureter.
Which one is the anterior most? Normal pelvis.
The vein.
So what about the also kidney and also? Just reverse.
Okay, now we have covered most of the history and clinical examination. Are you aware of what is paraneoplastic syndrome?
Yes. And yes. Should I define?
No, okay, tell me, just.
So the most common paraneoplastic syndrome is the raised DSR levels. Then there is hypertension due to renin production. There can be hyperglycemia due to PTH-related peptide release. There can be Stoffer syndrome due to IL-6 release. It is basically a non-metastatic liver dysfunction, which is reversible on nephrectomy. And there can be fever due to IL-1 production.
Okay, fine, you know about this. Let me ask another question. You said the commonest presentation is accidental. So, what's the next commonest presentation? Usually presents as fever. Fever. And PU of fever is still unknown only. Rates and finally give you. Very rarely, when do you think that eventually occurs? When there is a communication with the pelvis, then it starts bleeding. So it's quite a late in the natural history of tumor. Right. Let's move to differential diagnosis.
On the basis of paraneoplastic, what is internist tumor? Why so called? Carcinoma internist tumor.
So because of such varied presentation not pertaining to the renal lump itself, due to it was earlier diagnosed by the interns, like due to clinical features. Now it is for the radiologist.
That is possible as comes. Because of variegated presentations, so it has to go to first from the intern.
Can we have some differential diagnosis from your clinical presentation? Can you think of anything other than kidney here based on your?
Yes, sir. Lower urinary tract malignancies can also have similar presentation.
There is a mass.
Yes.
Lower urinary tract
will not be.
Now you have a mass on the right side and hematuria. Right.
A renal stone disease.
Does it become palpable? Kidney becomes palpable?
Only in fetal crisis when there is a stone which is obstructing the.
So intermittently, but this has been there all through.
Yes.
Right. What's the median margin of this tumor?
So I could not palpate the median margin.
You could not palpate. Then how would you differentiate between, if I'm saying that it is a soft tissue sarcoma and not the kidney, what's your objection?
So soft tissue again it will not be.
Symptoms, hematuria will not come.
Yes, sir. Only if there is invasion into the ureter.
Secondly, it would not cross the line in a kidney. You have not mentioned here. You said that medial margin is not, that because it must be deep in the center of the spine, isn't it?
Yes.
Can it be anything other than in kidney itself?
Yes, so benign pathologies like oncocytoma, angiomyolipomas can be.
More common than that. Those are really defined.
Palpable kidney, uniformly
Hydronephrosis or polycystic kidney.
Yes, but then hematuria will not be part of that. So you have a differential diagnosis, but then all findings are not to renal cell. So how are you going to investigate this patient?
First I will do some tests to confirm my diagnosis, beginning with the USG whole abdomen, which is now an extension of the clinical examination. So I will do that to firstly to find the origin of the tumor, from where it is arising, the nature of the mass, whether it is solid or cystic. Then I can see any local extensions if present can be seen. Opposite sided kidney can be visualized, and any regional lymph nodes can also be seen.
Are all the renal masses seen on ultrasound? What is the dictum?
Ultrasound is not a like.
So the larger the mass,
Yes, sir.
more
Better
chance of
detection. Yes.
So small masses
Can be
usually
investigated.
miss.
Yes. So the investigation of choice will be a CCD whole abdomen, and
You do an ultrasound, you shift the patient straight to CT scan or in between?
so we can perform certain blood.
What is the essential blood that you need to do before you do a CT scan?
So the kidney function. Yes.
So you do a urea creatinine. Okay. then what are you doing in the CT scan?
In CT scan, I would like, again, we will confirm where the mass is arising from and the local extent, how much, the extent of the tumor. We can also see the opposite side kidney, the functioning of the opposite side kidney. Apart from that, we can typically for diagnosis, CT scan on contrast and it shows contrast enhancement of more than 15 to 20 Hounsfield units. So that is very characteristic. Other than that, we can also see whether there is involvement of regional lymph nodes, any adrenal infiltration into the adrenal gland is there or not, any distant metastasis is there or not, and any renal vein or IVC thrombus is there.
If RFT is not normal, if urea creatinine is not normal, how are we going to proceed?
So we can go for NCCT, but it does not have that, like for confirmation we cannot do. We can do an MRI in such patients with or without gadolinium.
Yes, we have now MRI, and we have to find out why this is. If other kidney is not functional, obstructed, you have to deal with that first.
Also importantly, it will also, you need to know that where in the kidney is tumor.
Yes.
Whether it's in the upper pole, whether it's in the lower pole, whether it's in the pelvis, because it makes a difference in the management. So, fine. You have now a tumor which is in the upper pole of the right kidney. No regional lymph nodes, no renal vein infiltrate or vein thrombus.
So I would like to know the size so that I can do the T staging and thereafter I will proceed. So if the size is, if it's a T1A less than 4 centimeters, we can go for a upfront partial nephrectomy can be done. And
If it is 5 centimeters?
4 to 7 centimeters in selected cases, we can go for partial nephrectomy or nephron sparing.
10 centimeters?
10 centimeters preferably or radical nephrectomy.
So you said the upfront surgery as though there was something else what that was available. That's the reason why I kept on asking.
No.
Right. The surgery is the mainstay.
Mainstay.
In your case, 8 centimeters palpable. So what is your take on that?
Sir, radical nephrectomy will be done in this case.
Before proceeding for radical nephrectomy, like confirming by biopsy or such a big level, you go for biopsy.
So biopsies will not become the standard, but nowadays we do not perform a renal biopsy. It's not mandatory for diagnosing a renal lump. But there are recent studies which show that renal biopsy does not actually result in seeding and can be performed, but only with certain indications.
So lump is less than 4 centimeters. Then what? You go for surgery directly or go for some investigation?
So in such cases, we can go for a less than 2 centimeters. There's something called active surveillance. In patients who are elderly and probably not fit for surgery, we can go for active surveillance. That is, we'll in that case we need a renal biopsy.
Not having any comorbidities, patient is healthy and active. He is between 50 to 55. Would like to roll out the malignancy or not? So what finding on the CT measures so that you can predict the patient would have a benign pathology, like angiolipoma?
So minus 15 Hounsfield units will suggest like fat content, so goes more towards the diagnosis of
What is that scoring? Is there any unit?
Hounsfield units. Yes.
The hope is that you generally do not require a biopsy for the diagnosis. You can straight away proceed with surgery in most of the cases. Okay, fine. This patient has now got a renal vein thrombus.
So still my main modality of treatment will be surgery. In such case, I will like to confirm pre-operatively if there is any thrombus extension to the IVC or not. If it's limited to the renal vein, I will again go for a radical nephrectomy in such case.
Presence of thrombus with which stage, locally advanced or stage 4 or advanced stage? Presence of thrombus in renal vein is it advanced stage or locally advanced?
Locally advanced.
The extent of inferior renal cavern thrombus, does it alter your modality of treatment?
No, sir, actually, it does not. We still it is surgical management, but we might require a CT-based assessment, or like.
Depends on whether it is suprahepatic or
Yes, sir, or
infrahepatic.
infrahepatic.
So if there is a suprahepatic, you are going to have
Mobilization of the
mobilization.
liver and then yes, sir.
You are going to clamp the inferior vena cava above the hepatic vessels. So that's not getting possible. So you need to, do a
Cardiac
bypass
bypass,
to
yes.
maintain the otherwise tumor thrombus is just usually a very floating tumor. You can just milk it out without any problem. But over a period of time, it can get
Attached to the
vessel. That becomes a positive difficulty. Which kidney is at attack? Right kidney or left?
Left is at high.
Left is at attack.
What are the types, how will you assess whether you can at all remove this thrombus by milking it out or not? Any investigation that will tell you before?
MRI is a better investigation to
What
see
will it
if there
show?
is renal vein or the wall is involved, infiltrated or not.
Walls and vascularity in the thrombus.
Suppose the patient is a male patient, okay, he has got a left-sided mass. Any clinical examination which can give you a clue?
So we can check for the external genitalia. If the left-sided non-reducing varicocele will indicate a renal vein thrombus.
So you have come prepared with the RCC. Let me ask some questions on. Let's let it be hydronephrosis. Hydronephrosis. How are you going to manage that patient?
So first I need to ascertain whether what is the cause, because there might be stone disease or
Usual cause of hydronephrosis?
so in young age we can think of PUG obstruction.
It's a PUG obstruction, 35-year-old patient.
Then mainstay is surgery. The functioning of the kidney has to be seen.
How do you know that?
So we can perform scans like BAC3 or DTPS scans.
Straightforward. Straightforward scans. You have simpler investigations.
Do you think that an ultrasound will lead you to start with? Because you have started with an ultrasound.
Yes, sir. Ultrasound we can.
What is that you are looking in ultrasound?
The grade of hydronephrosis and function.
What is hydronephrosis? Then you can
Dilatation of the pelvic region.
It is an aseptic dilatation of the pelvic urinary system. And then what are you going to assess in an ultrasound in hydronephrosis?
Renal parenchyma.
Thickness of the renal cortex.
Yes.
How much is the cutoff value ultrasound? 15 millimeters. 15 millimeters. If it is less than that, there is a chance of the renal is
Still functional.
still not functional. So the next step is
So after ruling out any urine CS report, for aseptic dilation, we can go for a urine analysis.
Next step.
It's investigation. Right, you said something. Now you come back.
Functional scans of the kidney.
DTP and EMS
DTP and
scans. Okay. It's only 10% functional.
10%. So in such cases, we can go for a stenting can be done. No, the drainage of the can be done for the drainage, and we'll observe that if it is if
By and large, 10% is not salary, right? Except when you are dealing with a pyelonephrosis. If you're dealing with an infected kidney, you need to drain the kidney and see whether the function improves. So you don't generally do a stenting, you do a percutaneous nephrostomy. Allow the kidney to regain. Right. Now, kidney is mild hydronephrosis. What are your surgical options? Your upfront surgery.
So we can go for pyeloplasty procedures.
No. There are different methods. It's a mild degree, grade the disease. Then you have, why are you always having this stent business? Stent is, because there is a PUJ obstruction, you need to correct that.
Yes.
Oh, what are the other methods to correct PUJ obstruction? Stent will only bypass that and improve the renal function. It will not correct that structure, will it? So what you do for that? You heard about endoscopic methods like endopyrotomy?
Very absent. Just putting in a stent will be like inviting trouble again and increasing your problem for subsequent procedures, right? So you need to decide at what point in time you really want to put a stent or you want to proceed with the surgical endeavor if at all it is indicated, right? So don't think of stent straight away. Now first question.
If you have got a mild degree, hydronephrosis need to be graded, then you have something called an endopyrotomy. You come from above and do optical division of the structured area at the PUJ junction, and then possibly put a stent from above and then come off, right? And it will always be combined with an nephrostomy so that the two grades the patient will get into endopyrotomy. A larger grade of hydronephrosis means a surgical correction. What are the different types of surgical corrections?
One is a dismembered and one in which we are
And the other is non-dismembered.
non-dismembered, yes. So usually performed is the Anderson-Hines pyeloplasty, in which we are removing the redundant part of the dilated system, and then we are joining the two ends.
What is the basic principle behind this dismemberment? What do we try to achieve? We need to place the ureter in a position where it is different, so that
it is redundant pelviureteric dilated pelvis is excised and the ureter is placed at the most dependent position, right? And non-membered is just like something like a VY pasty or something like that. You just put a correction, right? And you put a stent and the stent is taken off electrically. Okay. This can be done both by open technique as well as by lateral. Right? Both these things are possible.
now suppose the patient has got bilateral hydronephrosis, then how will it proceed?
Basic principle of all real benign renal surgery or even malignant renal surgery remains one. Preserve renal tissue functionally as much as possible, right? So the same principle will get on either side. Question would become, do you undertake the procedure at center stage? Do you take this procedure on a sequential basis? If so, what guides you?
So I'm not very sure, but I think it is sequential.
Yeah, preferably sequential, and the worst side or more symptomatic side or more infected side should be treated first.
But before that, you need to see the lower tract also. In male patients, it can be due to benign prostatic hyperplasia or some urethral problem. So you need to
rule out
yeah.
the cause.
One patient. Today I examined and there was a loin swelling, there was a lump. Yesterday when I went to examine the patient, the lump has disappeared. What is that? Is there possibility in case of renal mass?
So this phenomenon is called uterus crisis, wherein there is usually by a stone, where the stone is obstructing the drainage pathway.
What is frequently we see? What is the common answer?
So basically the pain and the swelling is relieved on passage of...
Not pain was mild, but swelling is persisting. Next day swelling has disappeared. Again he comes, he gives such history, sir ऐसा होता है, फिर गायब हो जाता है.
So when
Is there any condition?
stone is displaced, then the patient passes a large amount of urine and there is relief of the symptoms.
What is the condition?
Datus crisis. I hope I'm pronouncing it correctly.
Can you do without stone? Such kind of thing?
So sloughed of papilla can also probably...
Something to do with kidney movement. Nephroptosis. Right. When do you say it is an approved doses? The excursion more than 5 centimeters. Right. So kidney is low lying, you will have all the trouble.
What is the term pseudo-renal tumor? Is it clinical word or some pseudo-renal tumor? What finding makes you that it is pseudo-renal? Many calcifications seen in the cystic mass, even in renal abscess and other conditions, we are showing the calcification, but is not, or there is no neoplastic tissue, that is called pseudo-renal, and that is imaging find, not clinical. What is the difference between the pyelonephrosis and perinephric abscess? What they say?
So, perinephric abscess will be when basically it bursts and spread to the perinephric tissue. So, and pyelonephric will be still limited to the kidney.
Miss outside the kidney and then what is the cell? What is the commonest presentation of an angiomyolipoma in clinical practice?
So, hemorrhage line stripe
Yeah.
can be there.
Usually it is picked up in CT scans and things like that. In clinical practice, the person is shocked.
Yes.
Have you seen one? Good to not to see one. So let's wind up. Thank you. Can I get all of the candidates who are for the dice, please? Possible? All the candidates who presented. Nipun Danford, Region Das.
All the candidates come up to the stage, please. All the candidates.
Region Das. Rakim Majinda, Priya Trajariya, Jit Rohan Kumar, Amartya Sengupta, Srija Roy, Rahul Pancha Chaudhary, Shashwat, Shrits Jera, Sritama, Abhishek Roy, Charlie John, Nidhi Sarai, and Sukanya Das. So I'm extremely happy to have these 14 students. So two people are absolutely. One is Amartya Sengupta and second is Rahul Pancha. I'm extremely pained by the absence of these two people. Let me put it this way, because you see the likes of Dr. Jha, Dr. Makalal Saha, Dr. Sudev Saha, Dr. Saugata Samanta, and the galaxy of all senior teachers, Sanjay, all these people are sitting throughout 2 days. Please convey to both the people who are distinctively absent during this time, and as though it gives an impression that we all seniors on an average experience of more than 35 to 40 years of post-graduation, we have to listen to one presentation by one guy from that. It really pains me. I'm sure that the teachers also share the same pain with me. There are many things which we try to achieve in an RRC. We try to reach you. I have communicated to all of you. I have tutored you many times, at least 2 times. You are imparting some kind of a discipline in your career later on. And a couple of things which again I would notice and I would like to tell you is that discipline is something which is very important in the upbringing of a surgeon. Keeping up the time. Today morning when we came here, 10 of the teachers were there and 2 presenters were there. It's unfortunate. I would say that one of the important things that you need to learn in your life is observing the importance of time. There is nothing precious in this world more than time is. So please understand that when you are expected to come at 8 o'clock for rounds, the patients as well as their relatives are eagerly waiting for you. If you start coming at 9 o'clock, your juniors is going to follow that. And your patients, they might want to go for work. They are going to be paid. So please, for heaven's sake, keep your time. If you don't learn anything from this, if you can learn this point in your life, keep the importance of time. I will be happy. I'm sure that most of my colleagues sitting here will be happy. Don't learn anything towards that. That's also fine. Right? Please tell these two people that we are very happy. Give them a round of applause because come out in the hard way, writing the examination to reach the stage, and I'm sure that it was an experience to go through in a clinical ground like this with distinguished faculty from all around the country. I'm sure that you have learned a lot. You people who have listened learned a lot. I personally have learned a lot from the questions that my colleagues have asked, because science is going. What is the knowledge doubling time today in India? Any idea? There's something called the knowledge doubling time. You read about that. The knowledge doubling time today is 52 minutes. Every 52 minutes, the knowledge in the whole world gets doubled. So you need to learn every 52 minutes to keep up the pace with the development of the science. This is not something joking you read and you'll find out. The science is growing so fast. So it was a difficult time for us to assess the candidates. However, we are going to give 2 third prizes, and the 2 third prizes are going to be for Priya Rajgaria from igims. She is locked with Sukanya Das, who presented the last A and B. And the third prize, can you bring the certificate and the citation, medallion, certificates plus the medallion? May I request Dr. Jha to come and give the presentation from it. You can give it to Raj. Thank you, sir. Thank you, sir. We'll give a chance to Dr. Jha, head of the department. Can you just give it to Dr. Sukanya Das? May I now request Dr. Makalal Sada to come forwards. Sir is going to give the prize to the second person, that goes to Nipun Dangor. Unfortunately, the first prize winner is absent. We don't discriminate that, he has done a good job, but then those who have come from his institution, please tell them we are thoroughly disappointed by his absence. And on behalf of him, may I request somebody else from IPGMR to come and receive the prize. He is Amartya Sen Gupta. May I request Professor Sudev Saha to come forward, and Dr. Sanjay also to join, please. Both of you together can give the prize. In absentia, receive the prize, but then make sure that you tell him that we are very, very sad. Sir, stay on, please. May I request all the faculty to come forward, please. So the students can move a little bit down to the downstairs. No, let them sit. We are on a ladder. I think you just will have to turn around. I think you need to turn around and give a good applause to all the teachers who have spent 2 days of your time to give them a good applause to the teachers. Thank you very much. I would request one of the students to come forward and say something if they wish so. If you can give a feedback, it will be great. One of the students can talk something.
A very good morning to all the respected faculty members and students present here. I'm Dr. Riya Rajkaria from IGIMS Patna, and I would like to convey my deepest heartfelt thank you to everyone present here. This experience was phenomenal for the students. The workshop with all the hands-on practice, be it the endo trainer or learning anastomosis and knots, that was very helpful to us. And the 2-day workshop here, the 2-day conference here, where we were listening all the faculties ask all the important questions which are going to help us not only clinically in our practice, like why should we ask this question, what should we infer from the findings, etc. That's going to help us in our clinical practice as well as in the exams. So thank you so much, sir, for organizing this and for helping us move forward in our career. Thank you so much, sir.
May I request Sarah to address the
RRC is one of the flagship program of ASI, and when it started, it was not so popular, but gradually it became a part and parcel of our all PGs, and they attend in large numbers, and day by day ASI has improved this RRC, and if you consider the awards that are not placed, people who are presenting here, first and second will be going to the national level, and who are going to national level, everyone are going to have their prizes, plus first, second, third, out of that place, we have some fellowship program, which is an added attraction for this whole RRC program. So I am sure the next batch of students will take more interest in this program, and I can assure you that if you go to the different regions, all good teachers come for this program, and this is what a model exam should go in your final examination. And it's a very good revision. I always tell my PGs that you should at least attend one RRC in at least 3 years. I'm not saying go every year, but at least in 3 years term, one should attend one RRC to have a glimpse of what usually go on in a user examination. So I hope we will continue with this confidence in ASI, that ASI will continue with this program, and I'm sure we will earn more laurels by attending this program. And I must thank Dr. Abraham, who single-handedly planned this, executed this, and most important is he has the whole data bank of all teachers of India. He has a data bank of all students of India who are doing PGs, and he make a personal contact. And because of him, that the participation is so good. And it's not the end. I find him keep communicating with the students beyond their senior residency also. That is also a personal touch from the background, and I'm sure there is his involvement in these activities. So I must thank ASI for continuing this nice program. Thank you.
Sir, his standing testimony, his daughter was second in one of the RRCs at the national level. She had been to Japan on ASI's fellowship program. She has completed, she's joined for surgical oncology in CH. She recently got cleared at MRCS. She communicated to me. I keep a track of all the students, what they do, and trust me, they are all doing very well. Some of you, at some point of time, may be helped by me also. I've been able to place many people abroad also in training programs. So I keep a track of many people. I'll leave this podium with thanking two important people also. One is the entire team of igims under the leadership of Professor Jha, Dr. Prem Prakash, Deepak, and the rest of the people. May I request them to stand so that the other people can keep them in reach. Thank you. Yeah. While we are getting arranged, this program being supported by Messrs. Torrent, the people from Torrent are here, Dr. Sahil, who is a PhD holder in pharmaceutical medicine, and he is working for Torrent. Give them a big hand as well. So I leave the podium with you. Thank you.
Now, from Torrent, Mr. Ashwin Hemant will say the vote of thanks, and this will be followed by lunch. The participants will go to the registration desk to collect their certificates after this vote of thanks. Faculties can have a dinner after the vote of thanks. Lunch after the vote of thanks.
Very good afternoon, and thank you everyone. Myself Ashwin and my entire team over here from the side, and we have the local team from Patna team, Mr. Tanmay, Mr. Thakur, and everyone, Mr. Santosh, who have come and organized this entire Torrent ASI design. This is in fact the second leadership course which we had in 2023, and physical form after the COVID. We have been doing this for many years, and what we saw today was one of the best brains in field of general surgery where they had an intellectual competition, and it in fact was really challenging and enlightening to see how the students were answering questions, and also the panelists were guiding them and teaching them, and I'm sure many of them learned a lot. So on behalf of the entire Torrent, we congratulate all the winners, Dr. Sukanya, Dr. Raya, Priya, Dr. Mukul, and Amartya. And we will be meeting them during the final round, which is going to be held at Visakhapatnam during the SC Con from 13 to 16. Right. So on behalf of the entire Torrent team, we thank all the students who have come from all different places. At the same time, all the eminent panelists who have given their time from their busy schedule, and that too on a weekend also, and the entire seniors who are here from IGMS surgery department. So I thank you all for making this a very successful and very enriching event, and I hope the support for our Torrent continues. Thank you. Thanks a lot.
Thank you. Thanks for
all faculties, delegates, members and staffs. Welcome you all to the third and the last day of Regional Refresher Course for ASI in igims Patna. Without any further delay, we will be continuing with our program schedule for today. I would like to call on stage Dr. Abhishek Roy from Calcutta National Medical College for his presentation on parotid tumors. And the paneling will be done by Dr. Matulal Saha from Kolkata, Dr. Shiv Shankar Paswan from Patna, Dr. Pankaj Bodras from Ranchi, and Dr. Madhumita Mukherjee from Kolkata. Thank you.
Very good morning to all the faculty members and my fellow colleagues present here. I am Dr. Abhishek Roy and I will be presenting a case on parotid tumor. So, starting with the patient particulars, my patient is a 54-year-old male, Hindu male, and he is basically a smoker. He is a resident of Kolkata and self-employed. Now, he presented to us with the chief complaints of a slow-growing painless swelling below the left ear lobule for last 15 years. If we further look into the history, the swelling had an insidious onset and it was first noticed by the patient 15 years ago. Thereafter it was slow growing, it was not associated with any kind of fever, pain or earache, no increase in the size of the swelling while eating food or chewing, no weakness of the affected side of the face was ever noticed and no problems in mouth opening was there. There was no major past medical or surgical illness. There was no history of radiation exposure to the head and neck region and no history of similar illness in the first degree relatives of the family members. There was no food and drug allergy and there was no prior treatment received for this illness. Starting with the examination, in general physical examination, he had an average build and nutrition. There was no neck nodes palpable and no generalized lymphadenopathy, and rest of the findings were unremarkable. Vital signs and all the other findings were normal. So quickly moving on to the local examination. Firstly, the inspection part. On inspection, we found a 6 cm cross 5 cm swelling. It was located near the left angle of mandible, and it was mainly in front of the left ear lobule. One important point is basically it was obliterating the normal groove that is usually present below the ear lobule. The swelling had a globular shape. The left ear lobule was slightly elevated by the swelling. The swelling had a well-defined margins on inspection, and the surface appeared to be smooth. There was no overlying skin changes. There was no pulsations, and no deviation of the angle of the mouth was noticed. So this is the swelling. As we can all see, it's located mainly in front and slightly elevating the ear lobule. there was the retromandibular groove, or the groove that is normally present below the ear lobule, is basically obliterated by the swelling. The surface is smooth, the margins can be clearly demarcated. Coming to the palpation, on exact measurement we found that the size of the swelling was around 6.3 into 5.1 centimeters. The shape was, as we confirmed found on inspection, it was globular. The surface was smooth and the margins were well defined. Coming to the position of the swelling, the position was located near the left angle of mandible and below the left ear lobule. On finding the extent of the swelling, superiorly it extended till 1 centimeter below the left zygomatic arch and inferiorly 1 centimeter below the inferior margin of the left ramus of mandible. Anteriorly, it went up to the anterior border of the left masseter muscle and posteriorly up to the left retromandibular groove. The consistency was somewhat rubbery, means variable consistency was present, and it was mobile in both vertical and horizontal axis, although on clenching the teeth or contraction of the masseter, it was somewhat restricted. The curtain sign was positive and there was no skin fixity present. So these are few clips. This is the curtain sign. This is the zygomatic arch. I will later mark it with the left hand. Beyond that, it's not going. And here we see the mobility of the swelling. It's mobile in both vertical and horizontal axis. The palpation, the further palpation methods, bidigital palpation was done, especially to feel the deeper lobe or deeper part of the gland, and it was found to be normal. The opening of the left parietic duct was also found to be normal. There was no sign of any kind of facial weakness or facial nerve palsy. The retromandibular, temporomandibular joint movements were all normal. Other salivary glands of the opposite sides and the same sides were normal, and cervical lymph nodes were not palpable. We did a bit of systemic examination as well. All were unremarkable, but what's worth mentioning is basically on abdomen there was no hepatosplenomegaly found. So to summarize, it's a middle-aged male who presented with a slow-growing painless swelling below the left ear lobule. On examination, it had a smooth surface, well-defined margin, mobile in both the axes, and the curtain sign was positive. Going by all this, this is a picture of the bidigital palpation, one hand over the cheek and other hand from inside. So going by all the points I told, the provisional diagnosis was, I thought that it was a benign tumor of the left parotid gland of the patient, and going by the incidence rate, I think it's a pleomorphic salivary adenoma.
Thank you. Your presentation, I leave it open to the examiner.
Okay, come back to the slide of histopathogenics. You started with the swelling, and you should mention that there is no history of rapid increase over it because 15 years swelling. And you should specifically mention a line that there is no history of any rapid increase of the swelling because that indicates some change in the swelling. Number two, you have to say that no problem in mouth opening. Why it is important? Which muscles are responsible for mouth opening and closing?
Sir, it's basically, I have mentioned here thinking about the temporomandibular joint movement.
The question is, which are the muscles which are responsible for
opening the pterygoid muscle, lateral and medial pterygoid, and the masseter muscle.
As such, muscle domestication.
These are not one more is there. Yeah. You mentioned the two pterygoids.
Yes, so medial and lateral pterygoid.
And the temporalis.
Yeah, that's it. So muscular domestication is not supplied by tissue. What else you would have mentioned? If you want to have some symptoms of there or facial nerve palsy, what specifically was? What you say no weakness affecting side of face.
The deviation of the angle of the mouth.
Number one. Number two.
From the history?
From the history, if we tell about, there will be pulling of the food in one side, means drooping of the saliva from the
eye. He can say that somebody is saying that your eyes are not getting closed while he is trying to close the eyes. Then somebody might be noticed that angle of mouth is deviated. And why is the food getting collected in the vestibule? Which muscle is the
buccinator? It's the buccinator palsy.
What buccinator does?
Buccinator means there will be.
Why do you normally?
Yes, sir.
What happens to the food?
So it gets collected in the gingivobuccal.
Normally, when you chew the food, the buccinator pushes the food in between the two alveolus. When the patient is paralyzed, food gets accumulated in the vestibule of the mouth. Fine. Next. You say no history of severe illness in the first three family members. If a patient has got a swelling for 15 years, low growing, at the end you come to diagnosis of pneumonia adenoma, what is the relevance of this statement? And often, for all PGs, you write often in the past history, no similar illness in the past. You always keep in mind, this line is to be used in situations there are some diseases which are characterized by relapse and remission. Like previously say Barger disease, Graves disease. So there are some diseases which can go to spontaneous remission. Otherwise, if you have a pneumonia adenoma, he may not have similar illness in the same site. This might have been out. This cannot be a situation that you disease as spontaneously. So unless this patient has got a disease which has got a clear genetic background, this statement does not stand that other family does not have a swelling in the same side of the face. That is not a relevant statement. Next. Next. When you go to local examination, try to understand. You started saying inspection. And I find your whole description is swelling itself. It's not that. When you are doing an examination for a patient and presenting with a swelling in the neck, you are heading for examination of the neck. Local examination of the neck. And then you can start describing the swelling itself. And then you have some other thing look in the neck. Whether the patient has got some deviation of the neck, any asymmetry of the neck. So the one thing is to describe the swelling. This swelling you are looking at in PG level, I would expect that you start saying that there is a swelling in the left parotid region. Let the examiner ask you, why do you see this parotid region? You are trying to say mandible, zygoma, below this. Instead of that, you straight away start saying that there is a swelling in the left parotid region, lifting the ear lobule, and this is the dimension of the swelling. How you have measured the swelling? You say 6 cm by 5 cm dimension. What you have used?
Measuring tape.
No, you are wrong. If there is a bulge, if you apply a tape, you do not measure the length and breadth of the swelling. This concept has changed. You have to use a vernier caliper. You put point up and down, medial, lateral, and use a caliper. If you use a tape, you are made the half of the circumference. So that is not to be done. That's why I asked the question. You should measure it vernier caliper. Go next. In inspection, don't comment about the angle of deviation mouth because you have determined the swelling. You will have a separate heading for saying examination for facial nerve pulse. That heading has to be there. What test you do for facial nerve pulse demonstration?
So for various muscles of the
keep on saying
basically.
What you ask the patient to do?
So popping out of the cheeks.
You start from one end to another.
Yes, so start from top.
Firstly, to look above, sir.
Yes, what
you do, sir, frontal belly of the occipitofrontalis.
What will happen?
Sir, it will, the loss of the wrinkles of the forehead will be there. So then to frown, sir, it's basically corrugated superciliary.
You need to fix the head before that, otherwise the patient will look upwards like this. So fix the head and then ask him to look up.
Then sir, for albicularis oculi, to close the eyes forcefully and then to puff out the cheeks for the buccinator.
What happens in that?
Sir, ma'am, we'll tell the patient to puff out the cheeks and we'll try to assess by pressing it, we'll try to assess the tone of the muscles and the resistance we feel. And then orbicularis oris means whistling or pouting of the face can be done. And lastly, the platysma means clenching of the teeth, they will be fanning out of the platysma muscle. Clenching.
Next, that's the next. Okay, you said by digital examination. Is it easy to examine the deep low the parotid gland by doing a right evacuation? Where do you place your inner finger?
Sir, in the tonsillar fossils, between the fossils.
So, have you tried? First thing is you have to inspect. For assessing the deep low, you have to inspect whether there is a bulge in the tonsillar fossa, number one. It is very difficult to do a bite examination because patient will gag. You put your finger in the tonsillar fossa, patient will gag and bite your finger. It is difficult to assess clinically. Okay.
It is the deep lobe is more seen than felt, right? And you made a statement that it is, deep lobe is palpated from you. Your deep lobe can be palpated.
Sir, if deep lobe is involved, then only it can be palpated.
So they said, sir, first inspect, there is other example.
You said something about fixing it on a message. Just come back to the slide. Restriction of movement. How to account for that? On your clinical demonstration, you showed it was freely mobile on clenching technique. But over here, you have said mobility in both vertical and horizontal axis is restricted. So how do you account for that?
Ma'am, actually, initially it should be done, mobility should be assessed twice, means once when the face is entirely relaxing and once when clenching the teeth, when the masseter becomes taut, and then we assess the mobility. It's basically suggestive of whether there is any kind of extension to the masseter muscle. I found it somewhat restricted but not entirely restricted. So I don't think that there is any cause of thinking in malignancy.
Don't make a opposite statement saying that it could possibly be restricted acceptance. I always quote a joke that you cannot be slightly pregnant. You are either pregnant or not. Right? Similarly, the swelling cannot be partially mobile. Either you make a commitment that it is mobile or not mobile.
And we come to the inspection part. Because you didn't describe about medicine lotion and all over the cell. That is the jump plus infection inside not be visible outside. So there sometimes allergic mentioned that also. And about medicine lotion. Will be research also.
If it's benign tumor, I will think in terms of either I have written pleomorphic salivary adenoma because the incidence of pleomorphic salivary adenoma is the most common, and it can be monomorphic adenomas like oncocytoma or basal cell adenoma. Adenolymphoma is less likely because adenolymphoma classically involves the tail portion, and we can also think about malignancy. Slow growing malignancy can be there. For that we need imaging, whether it's involved other structures or not. Going by the history, he is a smoker and means for last slow growing tumor, mucoepidermal carcinoma can be there. Because low grade mucoepidermal carcinoma often grows.
This is not a theoretical description of all what possibilities that can come in parotid swelling. Based on your clinical finding, what are the possibilities that you will implement?
It can be oncocytoma, it can be basal cell adenoma, or a low grade mucoepidermal carcinoma.
You have again listed the whole thing. What's your finding? Surface is smooth. Margins are well defined. The swelling is predominantly at the lower part of the parotid. 15 years of duration. Would you think that pleomorphic adenoma fits in with this dimension? Uniformly, you said rubbery intestines. Generally, we refer to either soft, firm, or hard, or variable. It's a classical consistency to pleomorphic.
So it's variable because
variable. Surface. What is the surface area?
Surface is a little bit bossulated, sir. Means
no, you refer bossulation in a larger swelling with larger masses. Bossulation. It could be rugged, right? In pleomorphic adenoma, is it smooth or irregular in general?
Pleomorphic adenoma.
You've seen pleomorphic adenoma?
Yes, sir. It's more or less smooth, sir.
Is it?
Seeing small tumors actually.
That's okay, but then again, the word by itself, pleomorphism.
Yes, sir.
It should be irregular.
Irregular, yes.
Surface, sorry, margins.
Margins, actually it should be irregular because of the presence of the pseudopods. There are something called pseudopods.
So none of your clinical findings are in favor of the pleomorphic adenoma. Your first differential diagnosis is pleomorphic adenoma. Long history, all these clinical
You mean the pleomorphic adenoma pseudopod come to the periphery of the swelling margin?
No, sir. It's
Pleomorphic does not involve the whole of the superficial lobe. It starts at the focus, and if you have a tumor there, tumor can have some projection in the interparenchymal material. It may not be going beyond the margin of the parotid. That is not very common. Why this cross pleomorphic adenoma? Why the term pleomorphic has come?
So based on the histology mainly.
It's not a macroscopic diagnosis. It's a histology. What in histology has described to say it's pleomorphic?
Sir, a variety mixed epidermal and stromal components will be there. Mainly epithelial cells, myoepithelial cells, cartilage, pseudocartilage, and often mucoid with myxomatous degeneration.
So based on histology, that is. So based on your clinical diagnosis, how are you going to proceed with this patient?
So firstly, I need to confirm my diagnosis. There can be two ways. Either first I need to do a baseline imaging of the swelling. I think sir, USG can be done, but CT scan will be better, sir.
Is it? If you have a tumor which is mobile, which has no facial nerve palsy, all the margins